First, we have the basal cell carcinoma, which is the most common type of skin cancer, okay, and generally found in the body surfaces which are exposed to the sun, of course, right? And please note that whenever you get a basal cell carcinoma, the patient will have a very good prognosis, because these tumors, they rarely metastasize. They are the most common one, and they have the very most favorable prognosis, right? What you can find, you will get a waxy pink-like lesion, okay, and with some pearly nodules, as you can see. These lesions appear very pearly, right? Sometimes patient can also have the ulcers at the center, okay, but the pulse are very important. You will get the pulse. In the center, you can sometimes get the ulcerations on the skin, right? So it would be a pearly mass with a skin color, sometimes a pink color, okay, and sometimes they can even get the ulcers. Sometimes they can get the telangiectasias also, right? So whenever we hear that type of lesion, that means they're talking about the basal cell carcinoma. They have these rolled up borders, as you can see. These borders are kind of very much rolled up, right? Okay, so once you do the biopsy of the patients, what you can get, you will get the nuts of these cancerous cells, as you can see. Okay, at the periphery, you will be having the palisadings, as you can see. Okay, in the centers, you'll be having this mass field. Okay, very important. So the basal cell tumors, they have the palisading nuclei, as you can see. If you zoom on this figure, you can see these parallel stackings on the, these type of things. These are the palisadings you will get. Okay. If I zoom out here, you will get these type of palisadings, okay, and they will form the nets, okay, and inside these nets you will have these tumor cells which are very disorganized way, okay, which are arranged in a very disorganized way, that you will get on the biopsy of the patient. Okay, then you have the keratoacanthoma, okay, which is generally seen in the middle age mans, okay, and sometimes in the elderly individuals. They are rapidly growing tumors, and they can resemble the squamous cell carcinoma because they have the ulcerations, okay, but they will appear as a dome-shaped lesion, as you can see. They will appear as a dome-shaped lesion, okay, with a center filled with the keratin, okay. They have a center which is filled with the keratin, okay, and they are a dome-shaped lesions. Okay, whenever you see a dome-shaped lesion with a center filled with the keratin, you will always think about the keratoacanthoma, right? As you can see here, this E figure, okay, you have this dome-shaped lesion, and in the center, this region is filled with the keratin completely. Okay, on the biopsy, you can get the same thing. You will get a cellular layer, and in that layer, you will be having, a center which is filled with the this keratin, right? Completely a mass, a keratin. Okay, this is the keratoacanthoma. Okay, please note that it grows rapidly. Okay, within 4 to 6 weeks, and then it spontaneously regresses. Stefan can ask you this fact about it. Okay, so it grows rapidly, and within a month, it will attain its maximum size, and after that, it will start regressing. Okay. Then you have the melanoma, and melanoma is a tumor of the neural crest cells. You guys already know that the melanin producing cells are derived from the neural crest cells. So they are positive for S100, right? And you need to know how to diagnose this melanoma. Okay, so this melanoma has 4 or 5 characteristics which you must remember. First is they are asymmetrical, okay, which means they are found in the unilateral surface of the body, in either of the hands, in either on either side of the face, on either of the leg, right? So on the unilateral surface of the body, they will be found, and they are asymmetrical, right? Second, they have a very irregular kind of borders. Whenever you see a patient, okay, with this hyperpigmented mass, with her, with having this regular borders, okay, and a homogeneous surface, that means they cannot be the melanoma, although they can resemble the melanoma. But if you get a very regular, a very sharp demarcated borders, then they cannot be melanoma. Melanoma must be having this very rough, or a very irregular kind of borders, right? Third, you have a color variation in them. You will having a brown color, black color, red color, pink color. Okay, so multiple colors will be there in a single lesion. As you can see in this figure also, you'll be having this brown lesion 10 colored and this dark lesion, right? And these are the pink lesions. As you can see, pink, brown, and red areas are seen, right? So on a single lesion, you'll be having a multiple colors. Third is the diameter. Step 1 will also mention the diameter of the mass. If they mention a mass with a diameter more than 6 mm, then it is highly likely the patient is having a melanoma. If the mass diameter is less than 6 millimeter, that means a very low chances patient can have a melanoma. And please note that these masks, they will grow over the time. They will evolve over time. The size of these masses will increase with the age of the patient. So they will always they always gives you this history, right? They will tell you that the mass, it seems like growing with the time, right? So it is very important. So these are the 5 features which you must remember for the melanoma. Okay. And step 1 can also ask you why the color variations are existing. So for the red areas, it is due to the vascular formation. It is due to the angiogenesis and the vessel dilation. Okay. The black and the brown areas are the side where the malignant cells are proliferating, and that's why releasing most of the melanin, and that's why these areas are hyperpigmented. The white or the gray areas, these areas represent those areas where the apoptosis of the cells are happening, of these malignant cells are happening. Okay, these areas represent those areas where the apoptosis of the malignant cells are happening, and the presence of these white areas, okay, will tell you that the tumor can still be recognized by the immune cells, which means you still have a very good prognosis. Okay, it is a very good thing if the tumor have this whitish or the grayish areas, right? Very important. So these type of areas, these type of colors will be present. Okay, step 1 can ask you about these color variations. Now you have different type of melanomas. One is the superficial spreading one. Okay, as you can see, this is a superficial spreading. Okay, it won't invade much. It spreads superficially on your skin, right? Second is a nodular type. As you can see, this is a nodular type. Okay, you have a multiple colors in them. You have this very irregular kind of borders. Okay, and the presence of nodule shows you that the patient is having a melanoma. Third, you have the lentigo maligna, very important. And these type of tumors, they have a very long history of this kind of a hyperpigmented lesion on the patient. They will always tell you that that this lesion is present on a very for a very long period of time on them, and recently this mass or this lesion start growing in the size. Okay, so this is the lentigo maligna. Then you have the acral lentiginous. Okay, and this and the location of this tumor is generally on the palms and the soles of the patient. Very important. And these are found in the extremities, that means on the palms and the soles. It is the most common type in the African American age group. So whenever Stefan give you a patient who is African American and who is having this lesion on the palm or the sole or the extremity, right? So it is always a case of lentigo maligna. Okay, sorry, acral lentiginous. Okay, so these are the types. Okay, one is a superficial spreading, second is a nodular, third is a lentigo maligna, fourth is a this acral lentiginous. Okay, these are the 5 types of the melanomas you can get. Okay, all these melanomas, they often drive by the mutations which are in the BRAF, within the the BRAF kinase. Okay, and you guys already know about other mutations which can happen because of this BRAF kinase mutation. Can anyone tell me?
Papillary thyroid and non-Hodgkin lymphoma and
And papillary thyroid, non-Hodgkin's lymphoma, melanoma, and
hairy cell leukemia.
hairy cell leukemia. These 4 type of cancers you can get because of this BRAF kinase mutation, right? And yeah, you need to know about this drug, okay, which is an inhibitor of this BRAF kinase, okay, vemurafenib, okay, and because it has a name NIB in it, okay, it is a receptor tyrosine kinase inhibitor, of course, okay, and yeah, that would be all about the melanoma. So patient will have a history of the pigmented lesion, as I told you about this tumor, okay, and they have a they have this kind of lesion for a very prolonged period of time, and now it darkens and growing in the size. That kind of a history will present in the patients having the lentigo maligna. Okay, that would be it. So any doubt on the melanoma?
No, thank you.
Then you have the squamous cell carcinoma, and the hallmark feature of the squamous cell carcinoma is the ulcerations. You will always have the ulcerated kind of mass on the skin, and whenever you have the ulcerated mass on the skin, that means a very high chances that this tumor could be the squamous cell carcinoma. Okay, it is the second most common type of skin cancer. It is associated with the immunosuppression, chronic non-healing type of wounds, and the arsenic exposures. Okay, it can appear on the face, on the lip, on the ears, on the hands. So you can say anywhere on the body it can appear, mostly on the peripheral locations, right? It is locally invasive and can spread to the lymph node. Of course, the metastasis is very rare. Okay, it is an ulcerative kind of mass. Okay, and on the histology you will get a keratin pulse. Okay, as you can see, this kind of a pinkish type of lesions. Okay, these areas will seen on the histology of the patient, on the biopsy of the patient. And whenever you see the creatine pulse, you will immediately know that the patient is having a squamous cell carcinoma. These are the hallmark features. So ulcerations and the presence of the creatine pulse, these are the two hallmark features of the squamous cell carcinoma. As you can see here, this is the ulcerative part. As you can see here on this figure also, you're having these ulcerations on the walls. Okay, and you guys already know that the actinic keratosis is the precancerous lesion for the squamous cell carcinoma. Actinic keratosis will present in the old age patients who have a very prolonged sun exposure history. They have this very rough sandpaper-like mass, okay, with no pigmentation at all. Okay, it would be a skin color mass or sometimes a tan color mass also, right? And what you will find on the biopsy of the patient with the actinic keratosis?
Dysplastic
Anyone?
cells.
Of course, you will find a dysplastic cells in any of the tumor. What other thing? Specific for it? Parakeratosis. Okay, don't forget that. You will get the parakeratosis and the actinic keratosis. Okay, very important to note. Okay, so any doubt on this page so far?
No, thank you.
Okay, so I think, yeah, I've covered everything on that page. Yeah. So for the diagnosis of these skin cancers, you first need to know how these lesions look like, whether they are having any rolled up borders. Rolled up borders with the ulcerations means the basal cell carcinoma. You will get the palisading and the nest-like masses, right? On the keratoconthoma, it would be a dome-shaped region with a center filled with keratin. On the melanoma, you will get the irregular borders, irregular colors, right? Or unilateral location will be there, right? And increase in size over the time will also be there, right? You will get a 5 type of these melanomas. Okay, for the squamous cell carcinoma, hallmark feature is the ulcerations and the keratin pulse.
We can't hear.
Yeah, we can't hear you.
Yes, we can't.
Oh, I'm sorry about that. Am I audible now?
Yeah.
Okay, so let me start it again.
Yes.
So now the arachidonic acid pathways, you have the membrane phospholipids. These phospholipids forms your cell membrane. Okay, and with the help of the enzyme, the phospholipase A2, these membrane phospholipids converted into the arachidonic acid. And now this acid has two pathways. One is the 5-lipoxygenase pathway, and second is the COX pathway or the cyclooxygenase pathway. Okay. Now, first let's discuss about the COX pathway. Okay, you have the COX1 and the COX2. The COX2 are found only when the inflammation is present. Okay, and the COX1 can express itself even without the inflammation, right? Like to maintain the cell tissues. Okay. So So using the COX-1 and COX-2, the arachidonic acid can be converted into the prostaglandins and the prostacyclins. Okay, the prostacyclins, you have the prostacyclin I2, okay, and the function of it is to decrease the platelet aggregation and to decrease the vascular tone, which means it works as it will decrease the formation of the clot and the thrombus, right? The function of prostacyclin is to decrease the formation of clot and to decrease the formation of thrombus, right? Second, you have the prostaglandins. You have prostaglandin E1, E2, and the prostaglandin F2 alpha, okay? And their function is to decrease or increase the smooth muscle tone. The prostaglandin E1 will decrease the vascular tone. E2 will increase this uterine tone, and 2 alpha is also increasing the uterine tone, which means these two agents can be used to increase the labor, okay, and they can be used as the abortifacient drug. They can cause the abortion, and that's why you need to avoid all those agents which can increase the prostaglandin E2 and prostaglandin F2 alpha concentration, okay, like the drug, the dinoprostone and the carboprost. Okay, very important to note. And apart from the prostacyclins and the prostaglandins, you also have the thromboxanes. Important one is a thromboxane A2, which increases the platelet aggregation and increases the vascular tone. Now you need to know what among these three, okay, what can be increased by the this COX1 and what can be increased by the COX2. Okay, so for the COX1, let me move forward. Yeah. For the COX-1, okay, thromboxane A2 will be increased, and the prostaglandin E2 and D2 will be increased. Whenever you have the expression of the COX-1, okay, you will be having an increased thromboxane A2 as well as a prostaglandins E2, D2, right? So I can say that whenever I have the COX-1, I will have an increased platelet aggregation. I can have the formation of the thrombus and the clot. Is that okay?
Yes.
And whenever I have a COX-2 expression, that means at the time of inflammation mainly, okay, it will decreases the platelet aggregation and causes the vasodilation. So expressing of the COX-2 is kind of very protective in the clot formation or the thrombosis, right?
Yes.
So whenever I give the patient a drug, okay, who is an inhibitor of the COX-2, okay, I can actually promoting the formation of the thrombus or the clot or the platelet aggregation, right? And whenever I give the patient COX-1 inhibitor, I can inhibit the platelet aggregation. Is that okay?
Yeah.
You heard about a drug which is a celecoxib, right? Which is a COX-2 inhibitor. And we use this drug mainly to inhibit the inflammation. Whenever I cannot use this aspirin in the patient, I use a drug which is a celecoxib, right? And one of the complication of the celecoxib is the thrombosis, right? You heard about it.
Yes.
Yeah.
Why is that happening? Because the COX-2 actually prevents the formation of the clot, but the COX-1 actually promotes the formation of the clot, right? Both COX-1 and COX-2, whenever they increased, they will cause the inflammation. So inhibiting the COX-1 either or the COX-2, I can inhibit the inflammation, right? So I can use either these NSAIDs or the aspirin drug to inhibit the inflammation, which are mainly to inhibit the COX-1, or I can use the drug celecoxib, which is mainly a COX-2 inhibitor. Okay, so it can inhibit the inflammation as well as the platelet aggregation. So the COX-2 inhibitor, which can inhibit the inflammation but can promote the platelet aggregation, right?
Yes.
So very important to note the function of the COX-1 and the COX-2. Both the COX-1 and COX-2 will promote the inflammation, will promote the pain, will promote the vascular permeability, vasodilation, uterine tone. The COX-1 will promote the thromboxane A2, that means it can cause a platelet aggregation, and the COX-2 will actually promote the formation of prostacyclin I2, that causes the decrease in platelet aggregation. Very important to note. Okay, so the aspirin can inhibit both the COX-1 and the COX-2, right? And as a result, both the thromboxane A2 and the prostacyclin I2 will be decreased. So you won't get any this thrombotic episode with that, right? Any clot formation won't happen, right? But with the celecoxib, it can have a pro-thrombotic effect because of decrease in the prostacyclin, the the prostacyclin I2, and whenever the COX-2 is inhibited, I will have a more COX-1, right? So more thromboxane A2 will be produced and less prostacyclin I2 will be produced. As a result, you will get a very prothrombotic effect, right?
Yes.
Yes.
So do note the function of the COX-1 and COX-2. Second is the lipoxygenase pathway. Okay, after lipoxygenase, you can have the formation of leukotrienes. Okay, and the function of the leukotrienes C4, D4, and E4 is to cause the increase in the tone of the bronchial smooth muscles, which means they can cause the bronchospasm, they can exacerbate the asthma, right? And that's why, as a treatment of the asthma, I can also give the patient inhibitor of these leukotrienes, right? Second type, you have a leukotriene B4, okay, which promote the neutrophil chemotaxis. Okay, and that's why by inhibiting the leukotriene B4, I can inhibit the inflammation also. Okay, so now let's discuss all the drug agents which can inhibit these pathways. First, you have the glucocorticoids. Okay, and the glucocorticoids can inhibit the phospholipase A2 as well as the cyclooxygenase. Okay, glucocorticoids can inhibit these phospholipase A2 as well as the cyclooxygenase. Both could be inhibited by the glucocorticoids, right? And as a result, you won't get the leukotrienes, you won't get the prostacyclins or the glandins or the thromboxanes, right? The drug celecoxib, it is a specific COX-2 inhibitor. Okay, aspirins and NSAIDs, they mainly inhibit the COX-2, and they also have an effect on, they mainly inhibit the COX-1, and they also have an effect on the COX-2. So they can inhibit both the COX-1 and the COX-2. Aspirin and the NSAIDs like diclofenac, ibuprofen, indomethacin, ketoconazole, and the naproxen, right? Then you have the drug which is a xylutin, and please note that this xylutin inhibit the lipoxygenase enzyme, okay, but the montelukast and the xifalucast, okay, they will inhibit the receptors for the leukotrienes. So xylutin inhibiting the formation of leukotrienes, and montelukast, xifalucast inhibiting the action of the leukotrienes, right? Very important to note. Okay, so by inhibiting the COX-1, I'm actually preventing the inflammation, and I'm also preventing the platelet aggregation. That means I can have an antiplatelet effect, okay, as well as a suppression of the inflammation. But this prostaglandin E2 is also responsible for the maintenance of your GI mucosa because it decreases the formation of acid, right? We've discussed that in the GI section.
Yes.
And does it by the IP3 DAG pathway or by the cyclic AMP pathway?
Cyclic AMP through GI.
Yeah, exactly. And now, if I use the glucocorticoids or these NSAIDs in the patient, okay, then I can have an inhibition of the prostaglandin E2, and as a result, my GI mucosa won't be stabilized, and as a result, I can get the ulcers. Right? Okay, and that's why the side effect of the glucocorticoid therapy or the aspirin and the NSAID therapy is the GI ulcers because of inhibition of this prostaglandin E2, right? Now, whenever I use any drug which inhibits the cyclooxygenase pathway, I can have more lipoxygenase pathway. Is that okay?
Yeah.
And whenever I have more lipoxygenase pathway, I can have more formation of the leukotrienes. As a result, I can get the exacerbations of the asthma, right?
Yeah.
And that's why one of the side effects of the aspirin therapy or the NSAID therapy is the asthma. Okay, but I won't get the asthma or the bronchoconstriction after the glucocorticoid this therapy because they inhibit both the formation of the lipoxygenase pathway as well as the cyclooxygenase pathway, right? By inhibiting the phospholipase A2. Okay, so I will get the exacerbations of the asthma in patients who are taking the aspirin, but I won't get that after the glucocorticoids because it inhibit both of the pathways. Any doubt so far?
I have one question.
Yes.
Glucocorticoids inhibit only COX-2 or both COX-2 and COX-1?
Both, because the main action of the COX these enzymes is by this NF-kappa B, right? When the NF-kappa B is present, they will activate these pathways, and mainly the function is in the inflammation. Okay, so both are inhibited. Very important to note. Okay,
Yeah,
and the glucocorticoids they mainly inhibit the inhibitor of the kappa B, right? They mainly inhibit the
It
kappa B,
activates
right?
kappa B. It activates kappa B. That inactivates NFK beta,
Yeah.
and that basically activates
Yeah,
COX2.
exactly. Because you know that in the in a normal scenario, you'll be having this inhibitor of the kappa B binding to the NF kappa B, right? And whenever the inflammation is present, whenever the cell gets activated, this inhibitor of the kappa B would be degraded, and the NF kappa B can be activated, right? So their function is to inhibit this NF kappa B, and that could be done by activating the inhibitor of the kappa B, so that it can inhibit kappa B, right?
Yes.
Okay, now let's talk about another type of NSAID, which is the acetaminophen. Okay, normally the NSAIDs have actions on the peripheral cells, right, on the body. Okay, for the COX-1 and COX-2. But this acetaminophen, it has action only on the cyclooxygenase in the CNS. Okay, and the main action of this COX pathway in the CNS is to promote the pain, and that could be done by the prostaglandin E2. You guys remember from general pathology lectures that the prostaglandin E2 is responsible for the pain, right?
Yeah.
And all of these interleukins, TNF alpha, they will promote the formation of this prostaglandin E2 so that a patient can feel the pain, right? So the main reason where you can use the acetaminophen is not the anti-inflammatory, but the antipyretic and the analgesic action, because it decreases the pain in the patient. And second thing, it can also inhibit the inflammation. Sorry, second thing, it can also inhibit,
Fever.
because
It reduces
it is,
fever.
because it is inhibiting the prostaglandin E2, and you guys know that this thing is also responsible for the fever, right? Because it increases this hypothalamus set point, right? So I can use the acetaminophen to control the fever. So two functions for the acetaminophen: one is the pain, and second is the fever. So it has both the antipyretic, which is to decrease the body temperature, and the analgesic to decrease the pain. But it do not have any anti-inflammatory action because it do not have any peripheral action, right? So so in the infants, whenever they get the fever, you always uses the acetaminophen but not the aspirin, okay, to avoid the Ray's syndromes, right? So please note the action of the acetaminophen, which is in the CNS. And does anyone remember, if I use the aspirin and I use the acetaminophen, what kind of drug interaction it would be?
Synergistic.
Synergistic,
Sorry,
or
additive.
think about it, synergistic or additive?
Additive.
I think additive.
Sure.
Not sure. I think so.
Okay, anyone else?
Additive, I think.
Okay, additive it is. Okay, whenever you have two agents with same mechanism of action performing same function, okay, it is the additive type. Whenever you have two drugs, okay, which are performing same function but different mechanism of action, then it is known as the synergistic, right? So if I use the acetaminophen as well as the aspirin in a patient, it would be a additive type of interaction. Okay.
Okay.
Now you guys already know that if I give the patient acetaminophen in too much amount, then it can be converted into the metabolite, which is an acetyl P-benzoquinone by the cytochrome P450, right? And it can cause a generation of the free radicals. Now I need the glutathione, okay, to fight with these radicals, right? But when the glutathione is depleted, okay, I can have the damage of the liver because of the free radicals, right? And I need to use the N-acetylcysteine to regenerate my glutathione so that it can fight the reactive oxygen species again, right? So overdose can cause the hepatic necrosis by the free radicals. Okay, and if I give this agent in a patient who is on the who is having a history of chronic alcoholism, okay, then even at the at the low doses, okay, I mean not the normal one, but a higher doses, but less than a normal toxic doses, I can get the toxicity even at that dose, okay, in a patient who is on the chronic alcoholism. Why? Because they will activate the cytochrome P450, and if even a small amount of overdose happens, but not at a toxic levels, subtoxic levels, I can get the hepatic necrosis in the alcoholism, right? So need to be very careful after prescribing this acetaminophen in a alcoholic patient. Okay.
Yes.
And that would be everything on this page. Any doubts so far?
No, thank you.
Okay, then you have the aspirin, okay, which irreversibly inhibit both the COX-1 and the COX-2. And the main action is on the platelets and on the inflammatory cells. Okay, so therefore, by inhibiting the COX-1 and COX-2, okay, it can decrease the synthesis of the prostaglandins as well as the thromboxanes as well as the prostacyclins, right? On the platelets, because it is inhibiting the COX-1 and the COX-2 irreversibly, okay, that means as long as that platelet is present, it cannot be functionable. I need new platelets to become functionable, right?
Yeah.
I give the drug, it act on the platelet. Okay. Now this platelet will be irreversibly inhibited. I need the new platelet, newly formed platelet to overcome this effect, right?
Yeah.
And because I'm inhibiting the platelets, I'm increasing the bleeding time. Okay. And the aspirin, it do not have any effect on the clotting factors. That's why PT and PTT will always remains same, right? Very important. So effect lasts until new platelets are produced because it is irreversibly inhibiting my platelets. So let's discuss the uses of the aspirin. Whenever you give the patient aspirin less than 300 milligram per day, okay, it can be used to decrease the platelet aggregation, okay, antiplatelet therapy. And the antiplatelet therapy is used in the patient with the coronary artery diseases, all right?
Yes.
Then you have the intermediate dose between the 300 to 2400 milligram per day, and it can act as an antipyretic agent as well as the analgesic agent. You use them for the pain control and for the fever control. High doses like 2400 milligram to 4000 milligram can be used for the anti-inflammatory purpose, like to treat the rheumatoid arthritis, to treat the gout. Okay, you can use these agents. Then let's discuss the adverse effects. First, we have discussed because of loss of prostaglandins, so you'll be having a GI ulcers. Okay, you can have the tinnitus, okay, which is ringing in the ear because of the cranial nerve 8 dysfunction. You can have the allergic reactions with the aspirin, okay, especially in the patients which are having the asthma, because you're inhibiting the COX pathway and activating more the LOX pathway or the lipoxygenase pathway, right? So you can have the exacerbations of the asthma we have discussed. Okay, they can cause the acute kidney injury. Okay, they can cause the interstitial nephritis. They can cause the GI bleeding also. Okay, because they are antiplatelet, right? The risk of Reye syndrome would be there when you give these agents in a very small child, right? For a viral infection. So that's why you always use the acetaminophen for that purpose, right? Toxic doses can cause the respiratory alkalosis, very important, and that's because of direct stimulating the respiratory center. This aspirin can directly stimulate the respiratory center. If you give them a very high amount, in a toxic amount, it can cause the hyperventilation, right? Second thing, these drug can also cause the metabolic acidosis. Okay, this agent can also cause the metabolic acidosis, right? And yeah, so it would be a mixed this respiratory acidosis and the mixed respiratory alkalosis and the metabolic acidosis would be there in the patient, right? And the treatment includes the sodium bicarbonate. And why I'm giving the sodium bicarbonate?
For its excretion.
How?
Well,
It-
because it's an acid, right? So you want to
Yeah,
neutralize.
exactly. Because this aspirin is a weak acid, and that's why if I give it in a very high amount, I can have the metabolic acidosis. And can anyone tell me whether it is a high anion metabolic acidosis or a normal anion metabolic acidosis?
High anion gap.
High anion
Why?
gap.
Why high anion gap?
Because basically we are adding acid from the outside. Aspirin is basically an acid, acetyl.
Exactly. And when can I get a normal anion metabolic acidosis?
When you're vomiting?
No, not the cause, the basic, the reason behind it, right?
When you add something that is unmeasured, when you add an
Uh,
acid that is basically unmeasured, like
I'm not adding any.
like
I'm not.
salicylic.
I'm
I
not
think
adding any acid in the non-anandamic metabolic acidosis. I'm not
It's
adding any acid in it.
loss of bicarb from the body.
Exactly. I'm losing bicarb from the body. I'm not adding any acid. I'm just losing my bicarbs, and as a result, I will get a non-anion gap metabolic acidosis because the chlorine will prevent the anion gap, right? Whenever I lose the bicarbonate, I will have a high chlorine in the body, and that will prevent the anion gap, right? But in case if I'm having extra acid in the body, then I can have an extra electrolyte also, right?
Yeah.
And that's how I can have an increased anion gap because of that, right? So because this aspirin is a weak acid, I'm adding any extra acid in my body, I can get the high anion gap metabolic acidosis. If I remove the bicarbonate from the body, then I can get the normal anion gap metabolic acidosis. Is that clear?
Yes.
Okay. And so yeah, whenever you encounter a patient who is having this hyperventilation, that means a very high breathing count, okay, and the patient is also having this metabolic acidosis, okay, you can get it by by the low pH of the body, okay, hyperventilation, okay, and yeah, a normal bicarbonate, okay, that's how you know that the patient is having a mixed metabolic acidosis and the respiratory alkalosis, and that means the patient could be on the aspirin overdose. Okay.
Sir, can you repeat that last sentence?
Yeah. What?
Can you repeat the final part of what you just said?
See, whenever you encounter a patient who is having a hyperventilation, that means a very high respiratory rate. First thing. Okay. Second thing, and even though you are having a high respirations, you are having a normal oximetry. Okay. Normally, body get the hyperventilation whenever the this oxygen level will lower on the body, right? Whenever get a low oxygen, I can get the hyperventilation, and that is a normal scenario, right?
Yes. Yeah.
But you're encountering a patient who is having a hyperventilation even after having a normal oxygen levels. I'm having a normal oxygen level in the body even though I am having a hyperventilation. That means something is stimulating my respiratory center to do that, right? Something external agent is doing that, right? Second thing, I'm also having a lactic acidosis, okay, and I'm having a this metabolic acidosis, which means a low pH would be there. And what are the features of the lactic acidosis? Sorry, what are the features of the metabolic acidosis?
Nausea, vomiting.
No, I mean about the pH and the CO2 and the bicarbonate.
pH low,
pH will be low. Okay, what about the CO2?
It would be low, right? Because
low or normal,
It would be low or it would be normal. Yes, because
normal.
it would be low mostly.
Yeah,
Okay, and what about my bicarbonates?
Low.
low.
Exactly. Whenever I have a low bicarbonate, whenever I have a low CO2, and I'm having this metabolic, and I'm having a low pH, that means I'm having a metabolic acidosis. So these things will be present, okay, and plus a high respiratory rate will be present. Okay, that's how you know the patient is having a mixed respiratory alkalosis and the acidosis. More we will discuss about them in the renal sections. Okay, we'll discuss how you can diagnose some mixed condition or how you can diagnose a compensatory conditions, right?
okay. Yes.
Okay.
No, I understand
It
how.
would,
Yeah, I understand why the respiratory alkalosis occurs early on, but
yeah.
the transition to mixed metabolic respiratory alkalosis, that's just bicarb being secreted by the body to
No,
neutralize.
It's just an acid being added in your body. The aspirin is an acid, right? It is
Mhm.
being added in your body that will cause a metabolic acidosis. So initially you are having just the respiratory alkalosis, but in the later, although you are, after
Oh,
you are having,
okay.
although initially you must be having a compensatory metabolic acidosis, no doubt, right? But it is not a compensatory metabolic acidosis, it is a primary metabolic acidosis, and that's why you call it a mixed metabolic acidosis and respiratory alkalosis.
Okay.
Okay, you can have metabolic acidosis by two ways. One is the compensatory, which is normal, right? And one which is a very much pathologic, right? Which
Yeah.
is not compensatory, and this is the type of you will get in the aspirin overdose, right? You will also get the hyperthermia because of this increase in the temperature. Very important to note. Whenever you have a cell-salad poison, you will always have a patient who's having this hyperthermia, very high temperature. You will get the hyperventilation, you will get the lactic acidosis, you will get the high and uncapped metabolic acidosis. You will immediately know that the patient is having a aspirin overdose. Okay, very important to note that. And if the patient is and please note that these agents are contraindicated in the hemorrhagic patients. These patients, they need the clot formation. And if you give these patients any antiplatelet agent, then the clot could be destroyed and the patient can get the hemorrhage, right?
Yeah.
And second thing, whenever you have the hemorrhage, you will have a very acute blood loss, and in these times, whenever you have a low blood volume, okay, you need the kidney to secrete the prostaglandin so that the blood flow in the kidney could be increased, right?
Yeah.
If you give the patient aspirin, then the prostaglandins level will be decreased. As a result, vasodilation won't occur. Because if you guys go back, you can see that this prostaglandin even actually decreases the vascular tone, right?
Yeah.
Yeah.
And that's why your kidney needs the prostaglandins in the time of low blood volume so that vasodilation can occur and blood flow to the kidney could be increased in order to kidney for survival, right? If you give these patients aspirin or any NSAIDs which inhibit the cyclooxygenase pathway, then you can get the kidney injury also, right? So in an acute blood loss, in the dehydration, in the hemorrhage, you cannot use the aspirin, okay, because of risk of the kidney damage. Okay, very important. You will have a decrease in perfusion, you will have the kidney injury. Okay, and yeah, you can also use the activated charcoal if the patient comes to a department in a very acute time, in a very short time, and you know that the drug is still in the GI system, it is not absorbed in your body, then in that case, you can give the patient activated charcoal to decrease the GI absorption. But if the time is very much prolonged, if you know that the patient, have this if this patient had the enough time in order for the drug to absorb, then in that case, we'll give the patient sodium bicarbonate to increase the excretion of the drug, right? So these are treatment thing you can give the patient with the aspirin toxicity. Any doubts so far on the aspirin?
No, thank you.
No, thank you.
Then you have the celecoxib. We have discussed that already. Okay, you're inhibiting this COX-2 with the help of celecoxib, and the COX-2 is only secreted or only get activated in the inflammatory cells. So I can use this agent to control the inflammation, right? It is found in the inflammatory cells in the vascular endothelium and mediate the inflammation and the pain. Okay, and this drug, it spares the COX-1 and inhibit only the COX-2. Okay, very important. So because the COX-1 is uninhibited, okay, the COX-1 is normal, I won't get any GI ulcers because of the celecoxib, okay, because my COX-1 is still functionable, right? But the COX-1 is responsible for the thromboxane A2 formation, and the COX-2 is responsible for the prostaglandin I2 formation. So by inhibiting the COX-2, I'm actually promoting the platelet aggregation, and one of the side effects of the celecoxib is the thrombosis. That's why, right? Very important. So what are the uses of the celecoxib? I can use them for the rheumatoid arthritis, for the osteoarthritis. Okay, and I will use this agent whenever I cannot use the aspirin or any other NSAID in these conditions, which means if the patient is having a prior history of the GI ulcers or something like that, in that case, I cannot give the patient NSAID because it can cause the GI ulcers in them. In that case, I need to avoid the NSAIDs, and I have to give the patient celecoxib, right? Very important. Any doubt?
No, thank you.
Okay. Then you have the NSAIDs, non-steroidal anti-inflammatory drugs. It includes the ibuprofen, naproxen, indomethacin, ketorolac, diclofenac, okay, meloxicam, and the piroxicam. You need to remember all these names. Very important to note. Okay, and unlike the aspirin, which is irreversibly inhibiting the COX-1 and COX-2, these agents will reversibly inhibit the COX-1 and COX-2. Okay, and as a result, it will block the prostaglandin synthesis, it will block the prostacyclin synthesis, it will block the thromboxane synthesis. You can use these agents and as the antipyretic agent, as the analgesic agent, and as the anti-inflammatory agent, but not the antiplatelet agent. Why?
Because they are
It's
reversible.
reversible. Yeah.
Exactly, because they are reversible, they are not irreversible. For having an antiplatelet defect, I need a drug which irreversibly inhibits my platelet, so that the platelets which are already formed, they cannot be activated again, right? So that's why these are not antiplatelet, they are just antipyretic, which means used to control fever, used to control pain, and used to control the inflammation. And the indomethacin can also be used to close the patent ductus arteriosus, because you guys know that the prostaglandins are responsible for the maintenance of the patent ductus arteriosus. So I use the indomethacin to close that. And if I want to maintain the PDA in a patient, I will have to give the patient alprostadil. And in what conditions I need the PDA to maintain?
Congenital heart diseases.
Like,
Tetralogy of Fallot,
okay, tetralogy of Fallot is one. And
transposition of the great arteries,
okay, second, and
Patent.
Tricuspidectory.
exactly. Yes. Okay, I need in
Tricuspidectory.
these, yes, in these time,
Preterm babies.
in these conditions, I need my PDA to be maintained, and as a result, I will give the patient alprostadil. And to inhibit the PDA and to close the PDA, sorry, I need the indomethacin, right? Side effects, again, just like the NSAIDs, they can cause a nephritis, they can cause a GI ulcers, they can cause a renal ischemia. Whenever I have, because the prostaglandins are required to maintain the renal blood flow. If I inhibit the prostaglandins, I will have the renal ischemia. I can also get the aplastic anemia in them, right? Very important to note. So yeah, these are all the side effects of the NSAIDs. Then comes the leflunomide. Okay, very important. Leflunomide. It is the inhibitor of the dihydroorotate dehydrogenase. And does anyone remember what does this enzyme do?
Conversion of orotic acid to UMP.
Exactly. And as a result, it will inhibit the pyrimidine synthesis. So basically, I'm using this agent, okay, to inhibit my nucleotide synthesis, and as a result, it will inhibit the T cell proliferation, because in order to proliferate T cells, I need the nucleotides to form the DNA, right? If I inhibit the proliferation of these, if I inhibit the formation of the nucleotides, in that case, I will inhibit the T cell proliferation, right? So these agents will be used for that. And yeah, just give me a second. The function of this enzyme, the dihydroorotate dehydrogenase, okay, is to convert the this CPS, the CP, the carmyl phosphate into the orotic acid, okay, not the orotic acid into the into the synthesis, into the pyrimidine synthesis, okay.
Okay, yeah.
The function of the dihydroorotate dehydrogenase is to convert this carmyl phosphate into the orotic acid.
Orotic
Okay,
acid.
and then the orotic acid will be converted into the UMP by the UMP synthetase, right?
Yes.
So the leflunomide prevents the conversion of the carmyl phosphate into the orotic acid. Okay, and that's how it will inhibit the formation of the nucleotides like the pyrimidines. Okay, and it will inhibit the T cell proliferation. I will use these agents for the rheumatoid arthritis, for the psoriatic arthritis. Side effects include a diarrhea, hypertension, hepatotoxicity, and the teratogenicity, because of course they are inhibiting all the cells which have the potential to divide, right? Like my GI cells, like my liver, like my kidney also can get damaged. Hypertension can happen, and teratogenic effects are also there. Any doubt on the leflunomide?
No, thank
No.
you.
Then you have the biphosphonates, okay, like the alendronate, ibandronate, acendronate, zelendronate, all of them have the name dronate in them, okay? And basically these are the pyrophosphate analogs, okay? What happens that these biphosphonate, because they are pyrophosphate analogs, okay, they will bind to the hydroxyapatite, and the hydroxyapatite forms your bone. Remember, in the lecture we have discussed the hydroxyapatite, which is calcium phosphate,
Yeah,
right? And during the bone resorption, the osteoclast cells, they will takes up this hydroxyapatite, right?
yeah.
But if I give the patient biphosphonates, then instead of this hydroxyapatite, okay, my osteoclast cells uh, will be ingesting all these biphosphonates, right? And then the biphosphonates, when they go inside the osteoclast cells, they will inhibit the metabolism of the osteoclasts. And as a result, the apoptosis of these cells occur. And that's how the biphosphonate prevent the dysfunction of the osteoclast cells. Is that okay? They will inhibit the osteoclast activity by causing the apoptosis of the osteoclast cells because they are the pyrophosphate analogs which bind to the hydroxyapatite. Okay, Stefan can ask you this fact, whether they are the analogs of the pyrophosphate or whether they are the analogs of the hydroxyapatite. So please note, these are not the analog of this hydroxyapatite, but the analogs of the pyrophosphate. Okay, and they will cause the apoptosis of the osteoclast. So they do not, they do not promote the bone formation, but they inhibit the bone resorption. Okay, whenever I use these drugs, you are inhibiting the bone resorption. You are not promoting the bone formation. Okay, but just inhibiting the bone resorption. So you use these agents for the osteoporosis, for the hypercalcemia, for the Paget's disease of the bone, for the metastatic bone diseases, for the osteogenesis imperfecta. Okay, and the side effects are very important. They can cause the esophagitis. We have discussed that already. Okay, and that's why you will always advise the patient to take these drugs with the water, okay, and remain upright for up to 30 minutes. Very important. Stefan can also ask you this. Okay, how you can avoid the esophagitis? By asking the patient to take these drugs in an upright position for 30 minutes and to take these drugs with the water, with a lots of water, right? They can also cause the osteonecrosis of the jaw, and they can cause the atypical type of femoral stress fractures. Okay, very important. And yeah, that would be everything about the biphosphonates. Any doubt on the biphosphonates?
I'm having one confusion. The hydroxyapatite is the organic part, right?
Hydroxyapatite is the inorganic part, calcium phosphate.
Okay. All right. Okay.
The collagen is this collagen is the organic part.
Yeah. Yeah. Okay. Okay. I got it. Yeah. Thank you.
Yeah. So any doubts so far on this page?
No, thank you.
No, thank you.
Then you have the teriparatide, which is the parathyroid hormone analog. If you guys remember, I told you whenever you have a pulsatile infusions of this PTH and a low dose of PTH is there in your body, then you can get the bone formation. But at a continuous secretion of the PTH and a high dose of PTH can lead to the bone resorption, right? So this analog is actually a PTH analog, okay? And this is the only drug which can stimulate the osteoblast activity, which can promote the bone growth. All of the agents which you guys know, they will inhibit the bone resorption, but this is the only agent that can promote the bone formation, right?
Yeah.
Okay, so it will activate the osteoblast cells, okay, whenever I give these drugs in the pulsatile fashion. Okay, the use of the drug is in the osteoporosis. They will cause the bone growth as compared to other agents which can inhibit the bone resorption, right? But because they're promoting the bone growth, they're promoting the osteoblast activity, they can increases the risk of osteosarcoma. Okay, and if the patient is of a Paget's disease, right, then you do not want any agent that can promote the osteoblast cell activity because you're already having a very high activity of osteoblast. Okay, and even you can get the cancer because of that. So you want to avoid the teriparatide or any drug which stimulate the osteoblast activity, right? So you will avoid these agents in the Paget's disease of the bone or any unexplained elevation in the alkaline phosphate, because having an increased alkaline phosphate means I'm having a high activity of the osteoblast, right? And I want to inhibit that. If I'm not sure why this alkaline phosphate is raised, if I know that the alkaline phosphate is right because of high level of PTH or because of this osteoporosis, something like that, then I can give the patient these agents. But if I have doubt that why this alkaline phosphate is level high, it could be because of the Paget's disease, right? Then I want to avoid these agents. You also want to avoid these agents who have a prior cancer history or any radiation therapy, right? Or those individuals who have a transient hypercalcemia. So any doubt on the teriparatide?
No, thank you.
I had one question.
Yeah.
The risk of osteosarcoma, That's because you would have just increased calcium, so you're more likely to generate bone. That's all, or increase osteoblastic activity. That's it.
Sorry, repeat it again, please.
I answered my own question as I was saying it. I'm okay. Thank you.
Oh, okay. Should we move forward now?
Yes, please. Thank you.
Yes,
Okay.
thank you.
Okay. So now comes the gout drugs. Okay. So you have a treatment. So whenever you encounter a patient with the gout, okay, they will always tell you the patient will be having this a very severe kind of joint pain. Okay, swelling over the joint would be there, tenderness would be there, redness would be there, right? And at that time, whenever you encounter such patients, you always have to give them acute gout drugs. You cannot give them these chronic gout drugs. If you give them these gout drugs, then you can have a very, a precipitation of the attack. It will make the condition even worse, right? So you won't give these agents in an acute attack. Whenever you encounter a patient in the emergency department with this severe pain, you will always give the acute gout drug first. And these includes the NSAIDs, glucocorticoids, and the colchicine. NSAIDs are the first line therapy, colchicine, second line therapy, and the glucocorticoids, third line therapy. We already know about the NSAIDs, they will inhibit the COX, and that's why they will inhibit the inflammations, right? By inhibiting the prostaglandins. Then you have the colchicine, which is a microtubule inhibitor. Okay, it will inhibit the microtubule polymerization, and you know that the polymerization is very much required for the formation of microtubules, and the microtubules are required for the chemotaxis of the neutrophils, because any cell or anything, if they want to move in your body, they need the microtubules, they need the roll tracks, right? Railroad tracks, right?
Yes.
Yes,
So by inhibiting the microtubules, I will inhibit the cellular movement, and in that case the neutrophil chemotaxis, right? And for the degranulation, even within the cell, I need the microtubules, right? In order to move these granules in the neutrophils, I need these tubules, right? So these agents can inhibit the neutrophil chemotaxis as well as the degranulation, and the neutrophils are responsible for the inflammation in my gout, right? So that's why these drugs are very much helpful. Secondly, they can also inhibit the leukotriene B4, okay, which is again a chemoattractant. Okay, so by inhibiting the microtubule, and second by decreasing the leukotriene B4, I'm inhibiting the neutrophil chemotaxis. Side effects include the GI distress, because these agents inhibiting the microtubule formation. Okay, and any cell which is dividing very rapidly will be affected, right? So I can get the diarrhea, I can get the nausea, I can get the vomiting. Okay, and yeah, so this is a major side effect of these drugs. Okay, and you can also get the neuromyopathic side effects, because they're inhibiting the microtubule. They can also inhibit the neurotransmitter the transfer, right? So you can get the neuro side effects also, which are minor ones. The third line therapy includes the glucocorticoids. You will use these agents only when the NSAIDs and the colchicine cannot be given, right? You can give these in the oral, intraarticular, or the parenteral route. Okay. And once you stabilize the patient, once you know that the patient is having a gout and you stabilize them, now you need to prevent the future effect, these attacks, right? And to prevent them, you need to give the patient prophylactic therapy or the chronic therapy, which could be any of these four agents. The first one is the probenecid, okay, which basically inhibit the reabsorption of this uric acid in the tubules, and as a result, it could be excreted from my kidney. And now, because it is this drug inhibiting the uric acid reabsorption, that means it will be increasing the concentration of uric acid in the tubules. That means I can get the uric acid calculus, and that's why these agents uh, uh, are contraindicated in a patient who are having any previous history of the renal colic. Okay. Secondly, you need to note that this probenecid also decreases the excretion of the penicillin. So basically, they are increasing the concentration of the penicillins in the body, right? So you can give the patient penicillin along with the probenecid to increase the concentration of these agents, right? So these three things you must remember. One, they inhibit the reabsorption. Second thing, they can cause the uric acid stones. And third thing, they can also increase the penicillin concentration. Then you have the allopurinols, okay, and the aripiprazole as well as the febuxostat. These two agents, they will inhibit the xanthine oxidase, okay, which is the enzyme that converts the this hypoxanthine into the xanthine, right? And finally, the xanthine will be converted into the uric acid by the same enzyme. So ultimately, these drugs are preventing the formation of uric acid in your body. Okay, you can use these agents in the treatment of any tumor, because in the tumor you can have the tumor lysis syndrome. To prevent that condition, you will give the patient allopurinol. Okay, and when you give these agents, the xanthine oxidase inhibitor, okay, and you need two drugs, okay, the azathioprine and the 6-merceptopurine, which are metabolized by this xanthine oxidase, okay, and they will be activated by the HGPRT, right? So if I give these agents, allopurinol or the febuxostat, I can increase the toxicity of the azathioprine and the 6-merceptopurine, because I'm decreasing the metabolism of these drugs, right? So whenever you give the patient allopurinol for the tumor lysis syndrome, you need to decrease the dose of azathioprine and the 6-merceptopurine to prevent the toxicity. Then you have the drug pegloticase. Also, you can have another drug, which is a rusfericase, remember?
Yes.
So the rusfericase and the pegloticase, they both actually solubilize the uric acid into the allantoin, okay, by activating the uricase enzyme, right? So now the uric acid will be converted into the more solubilized form, which is the allantoin. It could be easily excreted from the kidneys, right? So this is the pegloticase. And please note, all of these agents could only be used in the chronic gout therapy, as a chronic gout therapy. You cannot use them for the acute attack. Okay, in the acute attack, you will only use the NSAIDs, glucocorticoids, and the colchicine. Okay, any doubt so far on the gout drugs?
No, thank you.
No, thank you.
Then you have the drugs which are TNF alpha inhibitor, and the main use of these agents is in the rheumatoid arthritis, okay, and in the inflammatory bowel diseases, okay, or similar diseases like the rheumatoid arthritis, including the ankylosing spondylitis or the psoriasis. Okay, so in all the conditions where the TNF alpha is having a very major role, okay, you can use these agents. First one is the etanercept, and as the name suggests, it is a sapt recept. Okay, so it is the analog of the receptor of the TNF alpha. Okay, you have a TNF alpha receptor in your body, and these agents work as a TNF alpha receptor. So instead of binding to the real receptor, the TNF alpha will bind to these agents, thinking that these are receptors for the TNF alpha, and by binding, the TNF alpha will be inhibited. Okay, so these are the decoy receptors for the TNF alpha. Then you have the infliximab, adalimumab. These two drugs, you can forget about the later two. Okay, but these two must remember, the infliximab and the adalimumab, and these are the anti-TNF alpha monoclonal antibody, because they have the map in their name. They are the monoclonal antibody, right? And they will attack the TNF alpha and they will destroy it. Okay, so the etanercept, it will be binding and inhibiting it, and these antibody will attack the TNF alpha and will destroy it, right? And you will use these agents for the inflammatory bowel disease, the rheumatoid arthritis, ankylosing spondylitis, or the psoriasis. But before prescribing the TNF alpha inhibitor, you need to make sure that the patient is not having any TB infection, because you need the granulomas in the TB in order to contain the infection, right? If the granulomas are not there, then the infection won't be sealed off, and it will and the TB bacteria, the Mycobacterium tuberculosis, will be disseminated in your body, right? So if the patient is having a positive PPD test, which means the patient is having a infection of TB, you cannot prescribe these drugs. It will cause the dissemination of the TB, right? So before prescribing, you need to make sure the patient is having a negative PPD. This test is must before prescribing these agents. Any doubt?
Do we have to remember the clinical uses specifically, like for which disease this drug is being given?
You can have an idea, just not a specifically name, but you can have an idea, because all these in all these diseases, the TNF alpha is involved, right? In the rheumatoid arthritis, you're having the TNF alpha. Remember the interleukin 17 and TNF alpha, these are two main interleukins which are responsible for the rheumatoid arthritis, right?
Yeah.
Similarly, for the ankylosing spondylitis, also you're having the TNF alpha as well as the interleukin 17, right?
Yes.
And for the psoriasis, similarly, in the psoriatic arthritis, you are having the TNF alpha use and the interleukin 17 use. In the inflammatory bowel disease, like the Crohn's disease, you're having a granuloma formation, right, which is done by the TNF alpha,
Yeah.
right? So you don't need to remember name. You just need to have an idea. If your basics are clear, if you know that these diseases, they have the TNF alpha role in them, you can easily know that these agents can be used in these diseases, right?
Okay. Yeah. Thank you.
So just a basic idea is enough. Okay, so any doubt on this page?
No, thank you.
No, thank you.
Okay, so we are done with the this chapter completely, the MSK and the dermatology, right? And now we are about to start the neurology after a short break. Okay.
Yeah.
Okay, so we'll take a short break, and after the break, we'll start the neurology. First, we need to know how the brain actually forms, right? So at the very initial, you have this ectoderm, the mesoderm, and the endodermal layer. Okay, and you have this notochord in between. Okay, now this notochord will get activated. Okay, and it will stimulate the overlying ectoderm to become the neural plate, or the neuroectoderm. Okay, and this neuroectoderm will form the neural plate. Okay, and then the neural plate, it will form some neural tube and the neural crust cells. Okay, as you can see, the neural folds will form. Invagination of this neural plate will happen, and that will form the neural fold. And from the neural fold, you will have this neural tube, as you can see, and the neural crest cells, right? So it was the notochord which started the formation of the this ectoderm into the neuroectoderm that forms the neural plate. The neural plate will form the neural tube and the neural crest cells. And please note that uh, the stimulation of the notochord started at the day 18, and the formation of the neural tube will happen by the day 21. So, at the 3 weeks of the gestation, the formation of neural tube is completed. Okay. Now, when the brain is completely formed, okay, the notochord will become the nucleus pulposus, and you know that this nucleus pulposus is present in the intervertebral discs, right? You have two plates. Okay, one is the alar plate and second is the basal plate. Okay, and the alar plate is the dorsal plate, the basal plate is the ventral plate. If you guys remember the anterior horn and the posterior horn of the spinal cord, okay, and you know that from the anterior horn you have the origination of the motor nerves, right? And from the posterior horn you receive all the sensory informations and the proprioceptions, right?
Yeah.
So this anterior horn, okay, is formed from the basal plate, and the posterior horn is formed from the alar plate. Okay, so the alar plate form all the sensory structures, all the receptors or the sensory nerves. Okay, and it is regulated by the TGF beta. Okay, so all the dorsal horn of the spinal cord, the sensory nucleus of the cranial nerve 5, 7, 8, 9, 10, because these are the mixed nerve, they have both the motor component as well as the sensory component. The sensory component of these nerves are formed by the alar plate. You have the basal plate, which is present ventrally or anteriorly. They form the motor portion of these nerves, as well as the anterior horn of the spinal cord. Okay, and the formation of this plate is regulated by the Sonic Hedgehog gene. So whenever you encounter any patient with the paralysis, you can say that the basal plate part is damaged. The part which is formed by the basal plate is get damaged, and that's why the patient is having a paralysis. So step one can go one step ahead, and they can ask you after giving such patients, either the patient with the sensory loss or the patient with the motor loss, they can ask you about these plates. Okay, so do remember, and they can go furthermore one step ahead, and they will ask you how these plates are regulated. So it is by the TGF beta and by the Sonic Hedgehog gene. Any doubt?
No, thank you.
No, thank
Okay. Then when the neural tube forms, it starts forming your brain. At the very initial part, you have three segments. One is the forebrain, then the midbrain, and then the hindbrain. The forebrain is known as the proencephalous, which means very front. Okay, so the proencephalon is there. Okay, then you have the mesencephalon. Okay, and then you have the rhombencephalon, which is the hindbrain. The forebrain will form the telencephalon and the diencephalon. Telencephalon forms your cerebral hemispheres and the basal ganglia. Diencephalons form your thalamus, hypothalamus, and the retina. Okay, thalamus, hypothalamus, and retina. Okay, the lateral ventricles are present in between the cerebral hemispheres. So that means the lateral ventricles are also formed from the telencephalon. Third ventricle is present in near the hypothalamus, right? And it is formed by the diencephalon. Then you have the mesencephalons, which is the midbrain, okay? And it forms the midbrain, of course. And the cerebral aqueduct, which runs in front of the midbrain, it is all, run behind the midbrain, it is also formed by the mesencephalon, right? Then you have the rhombencephalon, which divided into two segments again, the metencephalon and the myelencephalon. Metacephalon form the part after the midbrain, which means the pons and the cerebellum. Okay, and of course, the part of fourth ventricle is also formed by it. Then the medulla, which is the lowest structure in your brain, it is formed by the myelencephalon. Okay, so telencephalon. Okay, then comes the diencephalon, then comes the mesencephalon, then metencephalon, and then the myencephalon. Okay, this is the organization of your brain. Any doubt?
No, thank you.
And after that, your spinal cord is present. You have two type of cells. One are the cells which are originate from the neural tube, and second are the neurograss cells. Okay, so the cells from the neural tube, they will, I can say the neuroectoderm, they will form the CNS neurons, all the neurons which are present in your brain, right? Which means the upper motor neuron included, they will be formed by the neural tube cells. Ependymal cells, which forms your ventricles, they will form by neural tube cells. Oligodendrocytes, which lines the CNS neurons, are formed by the neural tube cells, and the astrocytes, which maintain your brain, they will form by this tube. You have the neurograss cells, which forms the peripheral neurons, Schwann cells, which line these neurons. Okay, the glias, which are present in the periphery of the body, the melanocytes. Okay, as you guys remember the S100 marker, and the adrenal medulla. Okay, not the cortex, but the medulla part. Okay, these are formed by the neurograss cells. Okay, and yeah, and the brain meninges, okay, which are the arachnoid matter and the pia matter, these are also formed by the neurograss cells. What about the dura matter?
From the
Anyone?
ectoderm.
From the ectoderm or from the mesoderm?
I'm not sure about that.
Miss,
Anyone?
miss, miss,
Yeah, it
miss,
is. Yeah, from mesoderm. Okay, so do remember this one. So arachnoid matter, pia matter formed by the neurograss cells, and the dura matter is formed by the mesodermal cells. And the mesoderm also give rise to the macroglial cells, which are the macrophages of the brain. Okay, so step one can ask you what cells form from what structures, from the neural tube, from the neurograss cells, or from the mesoderm in the brain. Okay, any doubts so far on this page?
no.
No, thank you.
Then you have the neural tube defects. Okay, you have the spinal cord. Okay, and this spinal cord must be covered by the bone, right? Okay, now whenever some part of this bone is kind of missing, okay, that means your spinal cord would be exposed to the environment, right? And you call it a neural tube defect. Okay, now uh, you have the neuroforce, okay, which needs to be closed, okay, within the 4th week. Okay, and if the neuroforce fail to close, in that case the neural tube will become very open, and that can cause the neural tube defects. Okay, and because of the failure of closure of this neural force, you will be having a persistent connection between the amniotic cavity and the spinal canal. You have this spinal canal, around it you'll be having amniotic cavity. Okay, when the neurofolds do not closes, the spinal canal will be in a close contact with the amniotic fluid, and as a result, all of the neurotransmitters or many other markers, they will be secreted into the amniotic fluid. And by measuring the levels of these markers, these hormones, you can easily say whether the patient is having a neural tube defect or not, and that includes alpha fetoprotein and the acetylcholine. Okay, both the alpha fetoprotein and the acetylcholine will be released into the amniotic cavity in the amniotic fluid. And by measuring the levels of the alpha fetoprotein and the acetylcholine, you can check whether the patient is having a neural tube defect or not. When the patient have both the alpha fetoprotein level high and the acetylcholine level high, that means the patient is having a neural tube defect. Sorry, it is the esterase, not the acetylcholine, but the acetylcholine esterase, right? So whenever both these markers are high, that means the patient is having a neural tube defects. You can have the alpha fetoprotein level high in other conditions also. And does anyone remember?
Spina bifida.
Other than the neural tube defects,
Down syndrome.
Down syndrome. You can have the level of
Down
alpha
syndrome.
fetoprotein high in the Down syndrome, in case of twins, in case of increasing gestations, right? But the presence of alpha fetoprotein along with the acetylcholine esterase confirms a diagnosis of neural tube defects. Okay, very important to note. And you need the folic acid to prevent these neural tube defects. So, the folic acids are kind of very much regular or compulsory for any, female with a reproductive age, right? Vitamin B9, they will decrease the risk of neural tube defects. Okay, so let's discuss these defects. One is the spina bifida occulta, okay, in which you're having a caudal neurophore to close, a failure of caudal neuropholes to close, which means towards the tail, right? And as a result, the defect will occur, right? But you do not have any herniation of the spinal cord. Okay, you're having just this defect, as you can see. Okay, the wall is now not closed. Okay, but the herniation of the spinal cord is not present. Okay, and it is seen usually at the lower vertebral levels because it is a caudal neurophores, right? And the dura mater is intact. Okay, the dura mater, which is this part, it is still intact. Okay, and it is also associated with a tuft of hair or a skin dimple at the bony defect. Wherever the defect is present, you will be having a tuft of hair or a dimple is present there, right? And that's how you know that a patient is having a spina bifida occulta. That means the wall which is covering the spinal canal is now not present. Okay, very important. Second is the meningocele. Along with the spina bifida occulta, if you're having a herniation of the meninges, okay, then you can call it a meningocele. Okay, then you have the myelomeningocele, in which the spinal cord along with the meninges are herniated, as you can see. Okay, and the skin is very much thin over that defect. You can feel, a protruding mass over that area. You can feel it with your hands. A mass is present, and that's how you know that the spinal cord is herniated from this defect, right? Then you have the myeloschisis, in which, along with the herniation of the this spinal cord, you have an absence of the skin there. The skin is not covering the spinal cord. As a result, this spinal cord is completely exposed to the outside environment, right? And if the compression of this spinal cord occur at that part, you can have the paralysis, right? Because of the compression of the spinal cord at that part, okay, that any nerve below this segment will be paralyzed, right? So it is an exposed spinal cord or the neural tissue without any skin or any meningeal covering. A spinal cord can be easily seen through this defect, right? Then if the rostral neuropholes, which means towards the brain, if they fail to close, you can have the anencephaly, okay, in which your forebrain will be absent, calvarium would be open, okay, and you will get the polyhydramnios because it requires the brain, okay, to stimulate the respiratory centers to cause the respiration, and the respiration is required for the swallowing of the amniotic fluid, right? If the swallowing center is absent in the brain, you won't get the swallowing. The levels of the amniotic fluid will be increased in your body. You will get the polyhydramnios. Okay, so how will a polyhydramnios patient present you? There, it would be a patient, a female, for say she's having a 28-week gestation, right? Instead of 28-week, okay, it will appear that the patient is having a 36-week gestation, right? The size of the abdomen will be at a 36-week gestation for say. Okay, so that's how you know that patient is having a polyhydramnios. Whenever they have an abdominal gut which is much more larger than what is supposed to be at that gestation is, right? That's how you know that the patient is having a polyhydramnios. Any doubts so far?
No, thank you.
You have the myelomeningocele, okay, associated with the Arnold-Chiari malformation type 2, as well as a trisomy 18. Whenever you have a trisomy 18, and does anyone remember the name?
Edward.
Edward syndrome. So
Edward.
this myelomeningocele is seen with the Edward syndrome and the Arnold-Chiari malformation too. Okay. Yeah. Then you have another condition, which is the holoprosencephaly. Okay, in which initially in a normal condition, in a normal human, you will be having a two cerebral hemispheres, but in this condition the cerebral hemispheres are failed to divide. Okay, the separation of the two hemispheres is absent. You will have a complete hemisphere, a single hemisphere. Okay, it is usually occurs in the 5 to 6 weeks. You do need to remember that, of course, but you do need to remember that it happens because of a mutation in the Sonic hedgehog gene. Okay. And you can also have this defect with the Patau syndrome, which is a trisomy of 13. Okay, very important. Along with this, along with the this holoprosencephaly, you will also have something known as a cyclopia, which is the most severe form. And you can have the cleft lip and palate, which is the moderate form. Okay, you will have a cleft lip. Okay, you will have a cleft palate. Okay, and these are the very kind of least severe, you can say. The most severe form includes cyclopia, okay, in which you have a single eye. Okay, nose will be on your forehead instead of the normal location. Okay, so these kind of abnormalities will be found on your face. This is the cyclopia. Okay, pituitary dysfunction will occur. Patient can get a diabetes, right? And of course they will die soon. Okay, on the MRI you will see a monoventricle. Okay, normally you have two separated ventricles, okay, one on each side. In this condition you will be having a monoventricle, right? And that would be seen in the holoprosencephaly. And this is the example of a developmental field defect, okay, in which a single embryonical disturbance can lead to a multiple malformations. Okay, because in case of this holoprosencephaly, you will having the holoprosencephaly along with the cyclopia or the cleft lip and palate, right, and the pituitary dysfunction. So a one embryological defect are causing multiple other defects also, right? So this is the field defect. So if the step one can ask you in under what category you will place this example, this is the developmental field defect. Okay, it happens because of a mutation in the Sonic hedgehog signaling gene. Any doubt on the holoprosencephaly?
No, thank you.
Then you have the lesioncephaly. Okay, because in a normal brain you're having these sulcis and gyri, right? But in case of lesioncephaly, okay, these sulcis and gyri are absent, and you will get a very smooth brain without any sulci and gyri. Okay, it happens because of a failure of the neural migrations. Okay, it is associated with the microcephaly, okay, and the ventriculomegaly. So whenever you encounter a patient and on the MRI of the patient, you're seeing just a very smooth brain without any sulci and gyri, that means the patient is having a lesioncephaly. Okay, very important. And the drugs, yeah, these are drugs for the neurotic defects. The valproates can cause it, methotrexate can cause it, trimethoprim can cause it, paramethamine can cause it, right? So yeah, that would be all on this page. Any doubt?
No, thank you.
Okay, so we have discussed about the spinal cord malformations. Okay, we have discussed about the forebrain malformations. Now discussed about the posterior fossa malformations. In the posterior fossa of your cranium, okay, the cerebellum is present. Okay, and already because the space is only available for so much structures that are present in your brain. Okay, if any of the structure increase in the size, or if any of the size of the calvarium is decreased, then you can get the herniation of these structures. Okay, the space is limited in your brain. Okay, so in these disorders you're having a decrease in the size of posterior fossa, and as a result the cerebellum, which is present in the posterior fossa, it will be herniated, right? You have two type of carry malformations. One is the carry malformation 1, and second is the carry 2 malformation. In the carry malformation, in the type 1, you're having a very slight decrease in the size of the posterior fossa, and as a result, the cerebellum cannot be accommodated in it, and as a result, the cerebral tonsils will herniate through this part. Okay, they will herniate from the foramen magnum, as you can see. Okay, foramen magnum is basically a foramen where the spinal cord exits the brain, right? And through this foramen, the tonsils of the cerebellum will exit again, will herniate, right? And because only the cerebral tonsils are herniating and the space is very slightly decreased, this condition is very much kind of less severe. Okay, and it will only present itself in the adulthood. Okay, it will absent and or it will be asymptomatic in the childhood. It will present only in the adulthood, right? And what are the symptoms you will get because of decrease in the size of the brain capacity? Because of decrease in the brain capacity, you'll be having an increase in pressure there. Because of that, the patient can get the history of headaches. Okay, because of the herniation and compression of spinal cord, patient can get the gait abnormalities. Okay, and the symptoms will be very much episodic. You will get the symptoms of the headache and the gait abnormalities, then symptoms will be resolved, then again you will get the symptoms. So whenever you encounter any patient with the episodic headaches, okay, and you will run the CT or the MRI of the patient, on that you will find this kind of herniations. You will find the herniations there. That's how you know that the patient is having a carry formation malformation 1. Okay, so guys, tell me, if you encounter a patient with the acute trauma, okay, in that case also you can get the herniation, right?
Yeah.
So how will you differentiate whether this herniation is present because of the trauma or because of the carry malformation type 1?
In trauma, usually the brainstem is getting herniated.
Okay. While any structure can be herniated actually.
There is long history of headache, right?
Exactly. A long history would be present, right? In case of trauma, you'll be having a herniation only in the acute trauma. Okay, you won't have, it won't be like that you have a trauma now and you have the herniation years later, right? This won't happen, right? But in case of this carry malformation 1, you do not have any history of trauma, or you can have a history of trauma, but it is a very last period before, right? It would be have a very last distance between them, right? So a trauma which happened a year before, okay, it do not correlate anywhere with this herniation. Okay, it won't cause any herniation. So step 1 can try to trick you into this. They will tell you the patient is having a history of trauma for like 6 months before or 1 year before. Okay, and the patient is having a history of these episodes of headache. Okay, and you run the CT or the MRI of the patient and you get this kind of herniation. You know that this herniation is not because of trauma, but because of the carry malformation type 1. So herniation in the trauma you only get in the acute scenario, not in the chronic part. Okay. Yes.
Yeah.
Okay. Then you have the carry malformation type 2, in which you have a severely decreased in the space of the posterior fossa, and as a result, the tonsils along with the vermis is herniated out of the foramen, this magnum, the foramen magnum, right? And as a result, you can get the aqueductal stenosis because the cerebral aqueduct is run just anterior to it, right? And if the herniation of this vermis and the tonsils happen, then the cerebral aqueduct can be compressed, and because of the compression, you can get the ventriculomegaly. You will get the non-communicating hydrocephalus. Okay, and because these conditions are very much severe, they will present themselves in the very early childhood. Okay, and because the herniation is very much severe, it can compress the spinal cord, and because of the compression of the spinal cord, patient can also get the paralysis below the level of lesion. Okay, and this condition will be evident during the neonatal period only. Okay, so when you encounter a patient who is having a history of this ventriculomegaly, that means a bulging fontanelle would be present. Okay, the head size or the circumference of the head will be increased in these patients. They will be having a paralysis, they will be having a headache, and that's why they will become very much irritated. Persistent cry would be present. On the CT and MRI, you will see the herniation of the brain. That's how you know the patient is having a the carry 2 malformation, right? So if you encounter a patient with headache in the late adulthood, that means a type 1. If you encounter a patient, a neonate or a very early child, right, that means it is a carry 2 malformation. Then you have the Dandy-Walker malformation, in which you're having an agenesis of the cerebral vermis, right? And so that you will be having a cystic enlargement of the fourth ventricle, because the space, whenever the space is present in your brain, the ventricles will be dilated, right? They will try to occupy that space. Okay, and as a result, we will get the cystic enlargement of the fourth ventricle that will fill the space which is present in the posterior fossa. So in these two disorders, in the carry malformations, you will be having a decrease in the space. In the Dandy-Walker malformation, you will be having an increase in the space, right? You will get the non-communicating hydrocephalus because no obstruction is present. It just, whenever the space is present, the ventricles will expand and they will cause the hydrocephalus. You will get the spina bifida because of that. So please note that the spina bifida is associated with the Dandy-Walker malformation. Okay, and the myelomeningocele is associated with whatever disorder?
Carry 2.
Myelomeningocele. Yeah, carry 2. And the syringomyelia is associated with the carry 1 malformation. And we will discuss the syringomyelia now later. Okay. So please note the associations. These are very important. And because of this myelomeningocele, also patient can get the paralysis if you compress the spinal cord there with some external structures, right? Because the herniation of the spinal cord is present, it could be easily compressed by the external structures. It can cause the paralysis again, right? And please note, in the Dandy-Walker malformation, we'll be having an agenesis of the cerebral vermis only. The cerebellum would be present, but the vermis part will be absent. Okay. Any doubt so far?
Could you please explain non-communicating hydrocephalus?
In case of a non-communicating hydrocephalus, there won't be any, sorry. Just give me a second. Yeah. In case of a non-communicating hydrocephalus, we'll be having an obstruction in the passage of this fluid, the cerebral fluid, right?
Yeah.
Whenever the obstruction happened, now the ventricles cannot communicate with each other. And we call it a non-communicating hydrocephalus. Whenever the ventricular myelin is present without any obstruction, you will call it a communicating type of hydrocephalus.
Okay. Yeah.
Okay.
Thank you.
Yeah. We will discuss that later again. Don't worry about that. In the pathology section, we'll discuss all the causes of the communicating and the non-communicating hydrocephalus. Why these are happening, we'll discuss them. Don't worry. Okay. Now you have the syringomyelia. Okay, in which you're having an increase in the cavity in the spinal cord. In the spinal cord, you're having a central cavity normally, right? And whenever the cavity increase in the size, you call it a syringomyelia. Okay, it is a cystic cavity, syrinx, within the central canal of the spinal cord. You have the spinal canal, you have the spinal cord. Okay, and in the spinal cord, in the center, you're having the spinal canal. And whenever the size of this canal increase, whenever the cavity in this canal is formed, you call it a syrinx or the syringomyelia, right? And please note that the fibers for the pain and the temperature, that means sensory fibers, they will run very near to the central canal. As you can see, you have the sensory inputs. Okay, they will come to the dorsal root ganglion. From the dorsal ganglion, they will cross immediately and they will cross on the other side, and then they will run in the tracts. So they're crossing in the midline, and that's why whenever you have any cavity, it will first affect the midline structures, which means these structures for the these neurons for the pain and the temperature. So the very first symptom that you will get in the syringomyelia is the loss of the pain and temperature. Okay, and it will be a symmetric loss of pain and temperature. As the cavity increases in the size, it will also compromise other structures like the corticospinal tract. Okay, so as a result, we'll get the paralysis later in the period. Okay, so first of all, you will get the symmetric loss of pain and temperatures. Sensations from the upper extremities will be kind of normal sometimes. Okay, but they can be damaged again. Okay, doesn't matter. You will get first the loss of pain and temperature, then you will get the paralysis later in the period also, right? These are associated with the Carey malformation type 1. Okay, very important. And please note the most common location is cervical, then thoracic, and then the lumbar. Okay, very important. So it would be a patient who cannot feel any kind of pain. They generally give you a history of burns without any pain. So they will tell you that, while cooking food, they somehow burn their hand, but they did not notice it because they do not feel any pain. Okay, they will see the lesion and then they will realize that the patient got a burn. Okay, they will complain you this kind of a history, and then you immediately know that the patient is having a loss of pain and temperature. They cannot sense any temperature, they cannot sense any pressure, and because they cannot sense any temperature, then they won't know if they're getting any heat or not. So they will burn their hands very regularly because they cannot feel any pain. They wouldn't realize that they are getting any burn, so they will get this burn and they won't realize it. They will see the lesion and they will come to the department. They will tell you that they cannot feel or feel any pain, they cannot feel any temperature, and that's how patient is having a syringomyelia. It would be a bilateral, very important, not a unilateral. And in the later course of the disease, because of the cavity expansion, you can get the corticospinal tract affection also. Okay, they will be affected too, and that's how you will get a paralysis again. The upper motor neuron lesion they will get, right? And again, after a very prolonged period of time, when the disease expand, when the cystic cavity expand, they can also include these tracts. Okay, the proprioception tracts, the columns, and as a result, you will have a loss of proprioception also. Okay, so first are the pain and temperature loss, then the muscle loss, and then the proprioception loss. Okay, this is the syringomyelia. You will do the CT or MRI of the patient, and you can see this kind of a cystic dilation in a spinal cord, right? And that's how patient is having a syringomyelia. Any doubt?
No, thank you.
So wherever the lesion occurs, everything underneath that is going to be affected as well?
Yeah. Below that, right?
Yeah.
Yeah, of course, because all the fibers are running in these tracts, right?
Mhm.
So they will be affected too. Actually depends, right? At a very initial course, because only the fibers which are crossing at that segment will be affected. That means if there's a cervical location, only the hands will be affected first, right?
Yes.
Because all the fibers which are below these lesion, they will be running in these tracts. Okay, so they won't be affected. In the later course of the disease, when the tracts are affected, like the corticospinal tract, right, then you will get the loss of all the muscle functions and the pain and temperature below the type of lesion, below the lesion, right?
Okay. Okay.
Initially at the segmental part only, and when these other tracts are involved, like the corticospinal tract or the spinocerebellar tract or the spinothalamic tract, right, then you will get a damage below the this level of lesion also. Okay,
Thank you.
but at a very initial, you will get a segmental loss of pain and temperature only. So
Okay.
that's about the syringomyelia. So as you can see, it will be this figure is showing the loss of pain and temperature sensations at the level of C5 and T4, because this cavity is present at the level of C5 to T4, right? So all the pain and temperature fibers which are crossing in the C5 to T4 spinal cord location, they will be affected, and you will get the loss of sensation in this part of the body only, not below, not above. But in the later course of the disease, when the cavity expands, it can include the spinothalamic tract, and as a result, all of the structures below the lesion will be affected. Okay.
Yes, sir. Thank you.
I have one.
Then you have the yeah.
Yeah. Is there any reason why Chiari-1 malformation is associated with syringomyelia? Like, is there any reason behind this?
No, it's just a frequency. You can see, they identify the patients and they know that most of the patients who have the Carey malformation type 1, they can get a syringomyelia also.
Yeah. Yeah. Okay. Thank you.
Just a research type thing. Okay.
Yeah. Thank you.
Then comes the tongue development. Okay, and you divide the tongue into the anterior 2/3 and the posterior 1/3. Okay, from the sulcus terminalis, you have the sulcus terminalis, you have the foramen cecum. And does anyone remember what is function of this foramen cecum was?
Thyroid development.
Exactly. Not the thyroid development, but the duct
Thyroglossal
development.
duct. Yeah.
The thyroglossal duct development. Okay, and it is a remnant of the thyroglossal duct. Okay, from there you have the sulcus terminalis, which divides the tongue into the anterior 2/3 and the posterior 1/3. The anterior 2/3 of the tongue is formed by the arc 1 and the 2, the aortic arcs. You will study that later in the reproductive section. Arc 1 and 2 will form the anterior 2/3 of the tongue. Arc 3 and 4 will form the posterior 1/3 of the tongue. Okay. Now, this arc 1 and 2 are supplied by the cranial nerve 5 and 7, right? And that means the cranial nerve 5 and 7 are supplying the anterior 2/3 of the tongue. Similarly, the arc 3 and 4 are supplied by what cranial nerves?
9 and the superficial laryngeal nerve.
Yeah, you will have the 9th and 10th nerve, right? So the posterior 1/3 of the tongue is supplied by the cranial nerve 9th and 10th. Now, you have the motor innervation, which is supplied by the cranial nerve 12. So only the motor nerve, okay, which can cause a tongue movement, it is by the cranial nerve 12. Okay. You also have the cranial nerve 10, this 10 as the motor innervation, and it supplies only the palatoglossus muscle, okay, which will elevate the tongue during the swallowing. From the posterior part of the tongue, they will elevate the tongue from the posteriorly in order to swallow the food, right? Rest all of the muscles, rest all the functions, the motor functions of the tongue will be supplied by the 12th nerve. Okay. And yeah, so for the sensory ones, for the anterior 2/3, okay, the senses for the pain, temperature, okay, these are taken up by the, they're supplied by the cranial nerve 5, okay, and for the taste, which are the higher functions, it is supplied by the cranial nerve 7. For the posterior 1/3, okay, the majority portion is supplied by the cranial nerve 9th, okay, and it supplies both the pain, temperature, as well as the taste. And the very posterior part of the tongue, okay, it is supplied by the cranial nerve 10th, both the taste as well as pain and temperature, right? So for the anterior 2/3, the pain and temperature is supplied by the trigeminal nerve, right?
Yeah.
The taste is supplied by the facial nerve. For the posterior 1/3, the taste, pain, and temperature is supplied by the cranial nerve 9th, okay, and similarly the pain, temperature, as well as the taste in a very posterior part, a very small part of the tongue is supplied by the 10th cranial nerve. Okay, so for the taste, you have the 7th nerve, 9th nerve, and 10th nerve. For the pain, you're having the 7th nerve, 9th nerve, and 10th nerve. For the motor, you are having a 10th nerve and the 12th nerve. Is that okay?
Yeah.
That's how you got a tackling development. Any doubts so far?
No, thank you.
No, thank you.
So we have discussed the embryology part, and now let's move and discuss the anatomy and the physiology. First, you need to know about the neurons. Of course, these neurons will help in transmission of the signals, okay, in the nervous system. And please note that the neurons are the permanent cells. They cannot divide. They can only undergo the hypertrophy, but not the hyperplasia. Once these cells die, they cannot be regenerated. Okay. Okay. And yeah, and they receive the signal from the dendritic ends. Okay. Then they have the cell bodies, and they send the output from the axons. Okay, so you have the dendrites that will receive the signals. Okay, and then you have the axons which will give the output to the signals, right? And in between you have the cell bodies, right? And the cell bodies, they actually contain the nucleus and other cell organelles, like the rough endoplasmic reticulum. And the rough endoplasmic reticulum of the neurons is known as the Nissl granules. Okay, rough endoplasmic reticulum is known as the Nissl substance or the Nissl granules, and they will be stained by the Nissl staining. Okay, very important. So whenever you hear the word Nissl staining, that means you're staining the rough endoplasmic reticulum within the cell body. Okay. And the neural markers, they include the neurofilament proteins and the synaptophysin, right? And whenever you have any neuroendocrine tumor, you can have these markerized, the neurofilament proteins and the synaptophysin, right? Very important. Okay, so that's everything about the neurons. Every neurotransmitter is being synthesized within the rough endoplasmic reticulum. Okay, then it will go to the Golgi body and then it will be transmitted to the axons. From axons, it will be secreted out to send the signals, right? And for any nutrition, similarly, all of the axons are dependent upon the cell body, right? For the nutrition, for the neurotransmitters, for any function, they will be dependent upon the cell bodies, right? They contain every organelles, they contain the nucleus and every other protein. Then you have the astrocytes, and these cells are basically the most common type of biliary cells in the CNS. They basically support the CNS structures. Whenever any damage to the CNS happen, for like in case of infarction, okay, in case of any other damage, okay, these cells will proliferate and they will repair that damage. Okay, they will also act as a buffer for the extracellular potassium. They will store the potassium, right? They also causes the removal of the excessive neurotransmitter. Whenever the neurotransmitter present in the axis, they will remove it, they will store it. They are also a component of the blood brain barrier. Okay, basically they prevent any solute or any cell movement within the brain, okay, to enter into the brain. And they basically store the glycogen. Okay, so basically whenever your brain need the energy, it will come from the astrocytes, because these are the cells which are storing all the or the fuel for the brain, right? And whenever any neural injury happen, they will try to repair it. Okay, they will proliferate and they will cause the reactive gliosis. Okay, whenever the reactive gliosis is there, that means the astrocytes are being proliferating there. Okay, and they're repairing the damage there. The markers of the astrocyte is the GFAP. Okay, and they're derived from the neuroectoderm, just like any other CNS cell. Okay, very important. And the GFAP is basically acidic protein, so it will be a eosinophilic staining, very pinkish it will appear. Okay, any doubt on the astrocytes?
No, thank you.
Now, can anyone tell me, in the hyperammonia, okay, I'm having this cerebral edema, right? So which of the cell, these neurons or the astrocytes or microglial cells or the ependymal cells, which of these cell will will be swallowing, will be swelling in case of this edema? Whenever I have the yeah, it is astrocytes. Okay, whenever I have the hyperammonia, I'm having high level of which substance?
Glutamine.
Gluten.
Exactly. And the glutamine is osmotically active, right? All of the glutamine will enter into the astrocytes, and as a result, the water will follow, and these astrocytes will become very swollen. Okay, and that's how you get the brain edema, because of swelling of the astrocytes. Okay, the function of the astrocyte is to store the neurotransmitters, that includes the glutamate. But you know that in case of hyperammonia, all of the glutamate which is present in the astrocyte, it will be converted into the glutamine, and that causes the absorption of the free water, right? That's how you get the cerebral edema, because of swelling of the astrocytes. Okay.
Yeah.
Then you have the macroglial cells, which are the macrophages of the brain, right? Whenever any damage happen, whenever any inflammation in the brain happen, these are the macroglial cells which causes the inflammation there, right? In case of the infarction, if you guys remember, I told you one general rule: whenever you have any injury to the cell, okay, in the very first day you will get the necrosis there. Okay, then in 1 to 3 days you will get the neutrophils. Okay, after 3 days up to 7 days you will get the macrophages, right?
Yeah.
And the macrophages which will appear in case of brain are these microglial cells. So on the 3rd to 7th day, when you observe any infarctive structure, whenever the infarction occur in the brain, and you observe it between the 3 to 7 days, you can see the microglial cells there. Okay, and whenever a tissue damage happen in the brain, they will release inflammatory mediators. Okay, and they will cause the phagocytosis. Okay, whenever the damage happens. Okay, and the HIV in the brain, okay, it will affect these microglial cells. Okay, and whenever the HIV affects the microglial cells, it will cause a fusion of the microglial cells and can form the multinucleate giant cells in the HIV and in the HIV associated dementia, because whenever you have the HIV, you can have the dementia also, and you call it a HIV associated dementia. In case of HIV associated dementia, whenever you see the biopsy of the brain, you can see the multinucleated giant cells, and these are the microglial cells. Okay. Step 1 can ask you what structures in the CNS HIV infects. So these are the macrophages, also known as the microglial cells of the brain, right? Very important. Yes. So, and whenever they proliferate, they will form the glial nodules. Okay. Whenever the microglial cells activated and they start proliferating, they start causing inflammation, they will form the glial nodules. Okay. And these are kind of a non-specific finding which can happen with any CNS inflammation like the multiple sclerosis or the viral infection or the meningitis or the encephalitis, not the meningitis, but the encephalitis, right? So that would be everything about the microglial cells. They basically help in the scavenging, they help in the inflammation. Okay, in the 3 to 7 days, you will find the microglial cells. In the HIV, you can get the multinuclear giant cells, and they are the structures which form the glial nodules. So the reactive the reactive gliosis is caused by the astrocytes. Okay, and the glial nodules are formed by the microglial cells. Is that okay? Any doubt?
Can you repeat that, please?
The microglial nodules are formed by the microglial cells, the macrophages, and the reactive gliosis is caused by the astrocytes. Okay, the reactive gliosis is done in order to repair the tissue. Okay, and the glial nodules are formed to cause the inflammation. Okay.
And then the microglial cells, will they also swell up in ammonia because they also contain glutamate, or would they just release it all out?
They will release the glutamate completely, don't worry. And you will get, of course, you will get the edema of the microglial cells, but the major thing, because the astrocytes are the most abundant cell in the CNS, right? So these are the major cells which are responsible for the CNS edema.
Okay, so swelling of the astrocytes, is that a protective feature?
Yeah.
Or okay, so they're pulling the ammonia from the outside in to
It is their function to store all these neurotransmitters like a glutamate, right? It is their function. But in the pathology, whenever you're having this hyperammonia, right, instead of storing the glutamate, they are storing the glutamine, right? And
Yeah.
that's how they get the edema.
Okay, thank you.
So basically,
They are the victim of this hyperammonia. Okay.
What you cut out?
They are the victim of the hyperammonia. Okay.
Okay,
You can see it like that. Okay.
thank you.
I have one question.
Yeah, do ask.
So basically, astrocytes and microglia both are involved in inflammation, right?
Yeah, of course.
Okay. Yeah. Got it. Thank you.
At the inflammatory phase, you will get the microglial cells. At the repairing phase, you will get the astrocytes. Because after the inflammation, you always have the repair, right?
Okay. Okay. Yeah. Got it. Thank you.
Okay. Now you have the ependymal cells, okay, which forms the lining of the ventricles. Okay, and you got the modification of the ependymal cells, okay, which forms the choroidal plexus, the choroid plexus that synthesize or that secretes the cerebrospinal fluid. Okay, so whenever you heard about the ventricles, you will always think about the ependymal cells. Okay, and the modification of these ependymal cells are known as the choroid plexus, and this choroid plexus will produce the CSF. Nothing much to know about these cells. Okay, they are basically the ciliated simple columnar epithelium. Okay, because of the cilia, they can cause the movement of the CSF, right? Because if the cilia are not present, then the movement of the CSF won't be there, right? Because of the cilia, the CSF will get the movement. Okay, so these are ciliated simple columnar epithelium, and they will modify to form the choroid plexus. They will produce the CSF. They will cause the flow of the CSF. They will line the ventricles. Okay, any doubt?
No, thank you.
Now, for the transport of the axons from for any neurotransmitter to be transported in the axons, you have two types of transport. One is the anterograde and second is the retrograde. Anterograde means away from the cell body or from the nucleus, and retrograde means towards the cell body or the nucleus. Whenever you want to whenever you transfer any substance from cell body towards this axon and then to the intercellular space or the synapse. It is known as the anterograde transport. Okay. At the time of virus activation, whenever you have any latent whenever you have any latent virus in the cell body, okay, this virus can get activated. Okay, and the activation happens with the help of this anterograde transport. Okay, and the protein or the microtubule which is responsible for the anterograde transport is the kinesin. Okay, then you have the retrograde transport. Okay, and the protein, or you can say the microtubule which is responsible for the for the retrograde transport is the dynein. Any substance which wants to travel from the axons to the cell body, they need to go through this retrograde transport with the help of the dynein. So any virus, in order to become latent in my cell body, okay, they first need to enter the cell, which is done by the axons. From the axons, they uses the dynein to go to the cell body and become latent there. So it is the retrograde transport which is causing the latency of all these viruses, right? And the activation of all these viruses is done by the anterograde transport. Any doubt on that part?
No, thank you.
Okay, then you have the myelin. Okay, and myelin is kind of a conductor. Okay, sorry, insulator, not a conductor. Sorry, this myelin is actually an insulator. Okay, and it prevents the loss of charge from the axons. You have the axons, okay, and they contain all these charge substances like the electrolyte, like sodium, chlorine, bicarbonate, and other things, right? And whenever you want to transfer any nerve impulse, any action potential, okay, changes in these electrons will happen, okay, on these electrolytes will happen, and that will cause the transfer of these nerve impulses, right? And the function of this myelin is to prevent the loss of all these electrolytes or the charges from the axons. Okay, so this myelin is basically a insulating substance. Okay, they will wrap around the axons, as you can see, and this wrapping is done in the concentric form. As you can see, these are the layers, these are the layers which myelin is forming. Okay, the myelin is basically synthesized by the Schwann cells in the periphery and by the oligodendrocytes in the central nervous system. Okay, at the sites where the myelin synthesis is absent, you have the sites in the axons. As you can see, this is the axon. Okay, you have the myelin synthesis there, and you can see these myelin sheets are in the concentric layers. At the site where the myelins are absent, you can have a loss of charge there. Okay, and these sites contain lots of sodium channels. Okay, so basically, at these sites, because sodium channels are very much in a high concentration, okay, they can easily exit out of the cell. They can easily leak off from the axons, and that's how you get the saltatory conduction. You have the sodium channels here. Okay, the charges will leak out and they will come again there, right? You have this kind of a jumping type of neurotransmission, and this is known as a saltatory conduction. So basically, the main use of the myelin is to cause the saltatory conduction, and the saltatory conduction will increase the conduction velocity of the signals. Whenever you have the demyelination syndrome, which means you have a damage of this myelin sheet, you will lose the saltatory conduction, and as a result, the velocity of the conduction of the impulses will be decreased, and you will get the paralysis and other sensory losses because of that. Okay, so please note that the road of Ranviers, they are very much abundant in the sodium channels. Okay, and the function of the myelin is to prevent the charge loss. They basically work as the insulator. Okay, so if I just give me a second. Let us suppose this is a neuron, okay, an axon part of the neuron. And let us suppose I give the action potential here, right? And because of this action potential, the charges rise to this point, to this level, not the point, to this level. It is kind of a graph you can imagine. Now, I don't know, slowly, these charges will be lost from my axons, and the level of these charges will be decreased. And as a result, this action potential will travel up to a certain distance only before charges will be decreased completely. And then I need again any other stimulus to cause again this thing. right? And then again my charge will be decreased. Is that okay? You're getting me?
Could you please repeat?
See, basically what happens, I give the action potential or any stimulus here, right?
Yeah.
And because of the action potential, I will get a positive charge inside and a negative charge outside, right?
Yes.
So I have an increase in charge there, and you can draw a graph like that. Okay, this represents the charge and this represents the distance. Okay, this is a distance on the x-axis and this is a charge on the y-axis, right?
Yeah, yeah.
Now, because these charge can easily leak out from the membrane of the axons, and
Yeah.
that's why you're myelin, right? That's why you're myelin at the first place, right? Because this charge will be exiting out of these membranes. So what happens as this action potential travels through my membrane, as this action potential travels through my axon, the level of this charge will be keep on decreasing,
Yes.
right? And they will hit the zero. And then I again need the action potential like that, okay, to travel with this distance. So you can see that the action potential can only travels up to a certain distance only before it will die, right?
Yes.
Yeah.
Okay, so see, if I insulate my axons with the myelin, okay, if I insulate my axons with the myelin like that, then I will be having a very less charge loss.
Yes.
Yeah.
And as a
Yes.
result, my graph will be like that,
Mhm.
right?
Yeah.
So because of the myelin, because of the presence of the myelin, my action potential can travel up to a very far distance than without myelin, right?
Yeah.
And this is known as a space constant. Okay.
Yeah.
You guys getting
Yeah.
me?
Yes, got it.
Yeah, yeah.
Okay. And because you know that the velocity of the nerve of a nerve transmission depends upon is equals to the distance upon the time, right?
Yeah.
Yes.
Okay. The distance is keep on increasing. As you can see, the distance is increasing. Okay. And the time is also decreased slightly. So you'll get an increased velocity because of that. Because of this, mainly because of increase in the space constant, you're having an increase in the conduction velocity. Okay, the time taken for this impulse to travel from here to here is also decreased, and you will get a very increased velocity because of that. Okay.
Yeah, yeah.
And if you do not have the myelin, in that case, you will have a very decreased space constant. And because of this decreased space constant, you will have a decrease in the conduction velocity. So the function of the myelin is to prevent, is to make the resistance, is to increase the resistance in the cell, is to form the insulator around my axons to prevent the charge loss. Okay, and they also decreases the capacitance because the capacitance is inversely proportional to the resistance. Because the myelination is providing me the resistance, it will be decreasing the capacitance of my axons. Okay, Stephen can ask you these facts about the space constant, about the resistance, about the capacitance. Okay, so do remember this fact. Any doubt?
No, thank you.
No, thank you.
Okay. So in case of any axonal neuropathy, okay, whenever my axons get completely damaged, as a result, I cannot transfer my signal from one point to another point. Okay, the amplitude of my signal will be decreased. The amplitude, the height of my signal will be decreased. Whenever I get a demyelination, the conduction velocity of my nerve impulse will be decreased. Okay, please note a difference between the two. The conduction velocity is decreased in the demyelination, and the amplitude of my action potential will be decreased in the axonal neuropathy. Okay.
Yes.
Okay.
Then you have the oligodendrocyte cells and the Schwann cells, okay, which are basically forming my myelin. Schwann cells in the periphery, oligodendrocytes in the CNS. And please note that each oligodendrocytes can myelinate up to 30 neurons, okay, but each Schwann cells can myelinate only one neuron. One for, one Schwann cell for each neuron, okay, but one oligodendrocytes for 30 neurons. Okay, and because of this myelin, because of this myelination in the CNS, you will be having this white matter. Okay, the white matter is nothing but because of this myelin, it will appear as the white. Okay, the cell body where the myelin is absent, it will appear as the dark or the grayer. So you call it a gray matter, right? Which is without the myelin. So whenever you have a demyelination syndromes, you will lose your myelin sheath, and as a result, these white matters will become the gray matter, right?
Yeah.
And that's exactly what happens in the multiple sclerosis. Because in the multiple sclerosis, you will be having a damage, you will be having an autoimmunity against the oligodendrocytes, right? And as a result, the myelin will be lost. And you will get some plaques in the white matter. You will study about that, right? You will get some plaques in the white matter, and these are nothing but just the demyelinating plaques. Because of loss of the myelination, you will get the grayish appearance in the white matter, right?
Yeah.
Similarly, in the progressive multifocal leukodystrophy, you'll be having a damage of the myelin, and as a result, you will get the plaques in the white matter again, right? They will have the fried egg appearance whenever you look them under the microscope, and that's why the oligodendroglioma, you guys study that later, they will have a very fried egg appearance. As you can see, they have a very large nucleus and a very small cytoplasm. Okay, this will give them a very fried egg appearance. Okay, this is like that. Any doubt on the Schwann cells or the oligodendrocytes?
No, thank you.
No.
Then you need to know about the sensory receptors, which are found on your skin. Okay, first you have the you have the free nerve endings. Okay, and the free nerve endings are found in all the skin, epidermis, and some viscera also, and they basically senses the pain and the temperature. And the nerve impulses, okay, are taken up by the A delta fibers, C fibers. Okay, you will study about these fibers later in the next page, but note that the impulses from these free nerve endings, okay, they will be taken up by the A delta fibers and the C fibers. A delta fibers are the fastest fibers, and the C fibers are the slow fibers. Then you have the Misner corpuscles, which are again some sensory receptors which are found on the hairless skin. That means on the palms and on the soles. Okay, and they basically sense the position, frequency, and the vibration. So the position sense, low frequency vibration sense, and the touch. Okay, they will the impulses from these kind impulses of these kind will be transferred, will be sensed by these Misner corpuscles. Okay, and they will be transferred by the large myelinated fibers. Very important. Okay, if you have the myelin, then you have a very high speed, and that's exactly what you need in the position sense. You need the impulses to be so fast that you can immediately know what the position of your hand is, where the position of your hair is, right? So because of the position, because of the vibration, you need a very fast speed of the neurons there, right? So they have a very large myelinated fibers. Then you have the Pacinian corpuscles, okay, and they basically found in the deep skin layers and the ligaments and the joints. They basically sense the pressure and the vibration there. Okay, and again, because they are sensing the vibration and the pressure, you need the large myelinated fibers for that. Okay, you have the Merkel discs, and the Merkel discs are found on the fingertips. You can remember it by like the mnemonic, by the thinking about the marker, and you use the marker with the fingertips. You hold the marker with the fingertips, right? So you can immediately know that the Merkel discs are found in the fingertips. They basically sense the pressure, touch, and the position. Okay, and because they need to sense the position and the pressure, right? They need to be very highly myelinated, so that the impulses can be easily and very speedily transferred. Okay. Then you have the Ruffini corpuscles, which basically sense the pressure, any slippage over the surface of your skin, over the joints. So any kind of a slippage movement is detected by the Ruffini corpuscles. Okay, they are found in the fingertips, on the joints, and they basically dendritic ends with capsules, and they adapt very slowly. Okay, and so only for you have the free nerve endings for the pain and temperature, and rest all of them are basically sensing the position, vibration, or the pressure. right? Only the free nerve endings are sensing the pain and temperature. Rest all of them are sensing the position, vibration, and the pressure, right? Any doubt on the sensory receptors?
Do we usually get questions on these receptors?
I have never encountered any question on these receptors, but just for the, because I have to mention the wind to study them, of course, right? But I've never encountered any question on receptors so far.
Okay, thank you.
What they can ask you about the fibers, not receptors, but the fibers. And we discuss the fibers now. Okay, so you have three type of fibers. Okay, the A alpha fibers, A delta fibers, and the C fibers. Okay, and we are classifying these fibers with the diameter and the myelin. Okay, so for the A alpha fibers, they are very largely they have a very large diameter and they are myelinated. The A delta fibers, they have a very small diameter but they are myelinated. C fibers, they have a very less diameter as well as a very less myelinated or no, or unmyelinated. Okay, so A delta, large diameter, large myelin. A delta, less diameter but myelin. C fibers, less diameter, less myelin or no myelin. Okay, so because they are myelinated and they are large, the speed of the nerve conduction is very high in the A alpha fibers. Okay, and that's why these are present in the afferent motor fibers. They are the afferent motor fibers because you need a rapid movement of your hands, okay, or your feet or any part of your body, right? So the impulses must be very much high in the speed. They must be very much faster, right? And that's why you need the A alpha fibers as the motor neurons. So all the motor neurons, all of the motor neurons, they are the A alpha type. Okay. For the proprioception, like the touch, like the vibration, right? The proprioception should be fastest, right? And that's why all of the fibers which are taking the proprioception type of sensory impulses, they must be of A alpha type, like the Meissner corpuscles, the Pacinian corpuscles, and the Merkel discs. Okay, they are A alpha fibers. Okay, they are very much highly myelinated and they are a very high diameter because the proprioception must be fastest. The Meissner corpuscles and the Pacinian corpuscles, they are fastly adapting. Okay, and the Merkel discs, they are very slow adapting. Okay, if you think about the smell, okay, whenever you enter any room with a change in smell, you first encounter it very easily, right? But then you adapt to that smell and you cannot sense it anymore, right? But the another person who entered the same room, they can detect that the smell, a different kind of smell is present, right? And when they enter the room after some time, they cannot detect the smell anymore, right? Why? Because all of these nerve fibers which are taking the impulses for the smell, they are very fastly adapting. They will adapt to that in this environment and then they will stop sending the impulses for this environment, right? But the Merkel discs, they are very slow adapting. Okay, and whenever you hold a pen in your hand, a marker in your hand, okay, you will be know that the marker is still in your hand because the Merkel's discs are sending impulses for that touch, right? If it was the Meissner's or the Pacinian corpuscles, then after some time you cannot feel the marker in your hand because these corpuscles will be adapt to that environment very soon. Are you getting my point?
Yeah.
Okay, so note that point. Then you have the A delta fibers, which are small and myelinated. The temperature and the pain impulses are taken up by the A delta cells or A delta neurons. Okay, so basically free nerve endings, which have the pain and the temperature, they transmit their impulses with the A delta fibers. Then you have the type C fibers, which are unmyelinated fibers. Okay, they basically, the temperature for the cold, I must say, the cold temperature is sensed by the A delta fibers and the warm temperature is sensed by the type C fibers. The postganglionic autonomic nervous system fibers are also type C fibers. Please note, very important, I've encountered this question. I think it was in the UWorld, not in the main exam, but in the UWorld I've encountered this question. They've asked me about what kind of fibers are present in the postganglionic ANS system, right? And it was the type C fibers. They are unmyelinated, they are small fibers, and they basically sense the warm temperature as well as the pain. Okay. Whenever the damage happened to the small fibers, okay, you will have something known as a small fiber neuropathy, in which you get the positive symptoms. That means a burning pain and the paresthesias. Whenever you have a damage in the large fibers, okay, you will have a negative symptoms like the numbness, loss of temperature, and the pain. You always, uh, most of the times you always study that whenever a patient gets a neuropathy, they will have this burning pain and the paresthesias, right?
Yeah.
And that's because a neuropathy is affecting the small fibers. And then you also study that after neuropathy, patient is also having a loss of all the senses. They cannot sense the pain, they cannot sense the temperature, right? So in some neuropathies, you will get the pain. In some neuropathies, you will get the loss of pain. Both things can happen, and it depends whether the patient is having a damage to the small fibers or whether the patient is having a damage to the large fibers. Is that okay?
Yeah.
Yes.
So next time, whenever you hear the neuropathy and the patient is having a pain, you will immediately know that this pain is because of the small fiber damage. Any doubt on this page?
No, thank you.
Then we need to know about the action potential. Okay, we have discussed it many times although before. First, we have the impulse. Okay, and that will cause the opening of the sodium channels. After opening of the sodium channels, you will get a depolarization. Okay, and as you can see, as the depolarization progress from minus 70 to the plus 30, the permeability of the sodium, the permeability of the membrane for the sodium is increased. It will reach to a peak. Okay, when the membrane potential is plus 30, the permeability will be at the maximum, and at that time the sodium channels will start closing. Okay, and as a result the permeability of the sodium will be decreased, and as a result, and you will also have the opening of the potassium channels, as you can see. And the potassium channels, when when the membrane potential reaches at the peak, okay, the potassium channels will open, and as a result, slowly the permeability of the membrane for the potassium is increasing. And at that time, at this point, okay, when the action potential is around minus 30, okay, the permeability of the membrane for the potassium is maximum. So if the step 1 ask you, okay, they won't give you this diagram, they will give you just this figure, this graph, the graph of the action potential. They will ask you at what point on this graph the permeability of the potassium is maximum. So that you will choose this point, and the permeability of sodium will be maximum at this point. Okay, very important to note the permeability. They will ask you this. And yeah, so you will get the repolarization because of the closing of the sodium channels and opening of the potassium channels. Then you will get the hyperpolarization, and at that time the potassium channels will close, and you will get the resting sodium potassium ATS pump opening. So they will throw 3 sodium outwards, and they will put 2 potassium inwards, right? You will get a normalization of the resting volume potential. Is that okay?
Yeah.
That's everything I have written here. And the amplitude of this action potential is measured by this height. Okay, and you can see, because this sodium permeability is responsible for the height of this curve. So I can say whenever I have a high sodium conductance, I can have a high amplitude. Whenever I have a low sodium conductance, I can have a low amplitude, right?
Yes.
Yeah. And if I block my sodium channels, then I won't get any amplitude. I will get a 0 amplitude of the action potential, which means the action potential cannot be generated without the sodium channels, right?
Yeah.
And that's exactly what your sodium channel inhibitors do. The local anesthetics, which are the sodium channel inhibitors, that decrease the amplitude of the action potential. If the step 1 asks you their function, they're inhibiting the sodium potential, the sodium channels. They will ask you what effect they can put on this action potential curve. So please note, they will decrease the action. So they will decrease the amplitude of this action potential curve. Is that okay?
Yeah.
Good. Okay, then you have the peripheral nerves. Okay, and you guys study one thing about the axons, that it is the largest cell in your body, right?
Yeah.
And do you guys know that every nerve in your body, they contain only single axon. From my ganglia, which is in the neck or or along the spinal cord, from that ganglia up to my fingertip, I have a single axon, a single cell. Okay,
Yes.
so these nerves, the peripheral nerves, they contain multiple single axons only. Okay, I have a synapse, one in the ganglia part only. Okay, and then in the spinal cord, I do not have any synapse anywhere along that. Okay, so from my ganglia up to my cell body, sorry, up to my fingertip, I have only a single axon there. And that's why the book mentions that these axons are the largest cell in my body. So these peripheral nerves, let's discuss about them. They have three layers. One is the endoneurium, second is the perineurium, and third is the epineurium. Okay, so you have the nerve fiber, which is a single cell. Okay, multiple nerve fibers are surrounded by the endoneurium, as you can see. Okay, then a bunch of these nerve fibers. Okay, the multiple endoneurium, these are surrounded by the epineurium. Okay, and finally the epineurium is surrounded by the perineurium. Sorry, I said it wrong. The endoneurium is surrounded by the perineurium. Okay, and then the perineurium, multiple perineuriums, as you can see, they will be surrounded by the epineurium, and that forms the nerve trunks. Okay, so an individual nerve fiber is surrounded by the endoneurium. A bunch of these neurofibers along with the endoneurium is surrounded by the perineurium. Multiple perineuriums are surrounded by the epineurium. Is that okay?
Yes.
And this epineurium, it also contains the blood as well as the vesicles, right? The vasa vasorum. Okay, so that's how that is the organization of your single nerve in the body, like the radial nerve, like the median nerve. That's how they are organized. Okay, all of these nerves contains the multiple these bundles of the nerve fibers, and all of the bundles of the nerve fibers contain a single axons, right? Okay. Any doubt on the peripheral nerves?
Do we have to learn that those layers, like where specifically each layer lies?
Yeah, you do need to remember, because of some syndromes which can which can cause the inflammation of the epineurium. Some syndromes can cause the inflammation of the endoneurium. Okay, like the Guillain-Barré syndrome. Remember, it can cause the inflammation of the endoneurium.
Yeah. Okay.
So for that purpose, you need to remember. It is similar to that of muscles. If you guys remember the muscles, the individual muscle fiber is surrounded by the endomysium, right?
Yes.
And then a bunch of these muscle fibers are surrounded by the perimysium, and then the multiple perimysiums are surrounded by the epimysium, right?
Yeah.
It is very much similar to that also. And you get in case of polymyositis, you get the inflammation of what part? Polymyositis, remember? In the last class, we have discussed that.
Endomysium.
Endomysium, right? And on the myositis, in which part you will get the perimysium? Yes.
Perimysium.
Okay, so that's why you need to remember all these structures, because once they give you the biopsy of the patient, if you see the individual muscle fibers and the cells there, then you know that the patient is having a endomysium or the endoneurium inflammation. If you see a bunch of nerve fibers and the inflammation or the inflammatory cells are surrounded these bunches, that means the patient is having a perimysium inflammation or the perineurium inflammation, right?
Yeah.
So for that purpose, you need to remember all these layers. Then you have the nerve damage and the nerve repair. Okay, you can have a nerve damage by two parts. One is a dissection, and second is the necrosis. Okay, when you have the necrosis, you call it an infarction, you call it a stroke, right? Whenever you have a dissection, you call you call it a dissection, of course. Okay, and then the repair of these nerves happen. For a dissection, you have the chromatolysis. Before that, we need to know about the type of nerve injury. Okay. One is the death of neuron because of the ischemia, because of the infarction. Okay. So step one can ask you the microscopic findings of these axons whenever a cell injury happens. Okay, depending upon the type of injury, what kind of microscopy you will get. Step one will ask you this. Okay, so for the ischemia, please note, it will be an irreversible kind of cell injury. Okay, very important. What you will find on the microscopy is the shrinkage of the cell body. See, whenever you have a necrosis, I told you, because it is an irreversible cell injury, you will always have the swelling. Remember? General pathology. There is an exception in the ischemia of the neurons. Whenever you get the ischemia of the neurons, you will see the shrinkage, not the swelling. And does that means that I'm not having swelling in my CNS because of ischemia?
No, we do have edema in the brain because of ischemia.
Exactly. I do have the edema in the brain because of the ischemia. You guys must have heard about it. Whenever I get the infarction in my brain, I can get the high intracranial pressure. I can get the edema of the brain. I can get the herniation of the brain. Remember?
Yes.
So I do get the edema. I do get the cellular swelling, but I cannot detect it on the microscope, because when I do the microscopic this imaging, what I see is a shrinkage. The swelling period is already over. Okay, the swelling do present, but at the time I detect it, I will see only the shrinkage of the cell. I won't see the swelling. Okay.
Okay.
So whenever I get the ischemia, I do the biopsy of the patient. Whenever they die, of course, okay, I cannot do the biopsy in a very living patient. So when the patient died of the ischemia, I do the biopsy, and on the biopsy, what I found in a very first day, within 24 hours, I will see the shrinkage of the cell. If it is if this is my normal neuron cell body, I will see the shrinkage of my cell body. Because the size of my cell body is now decreased, the density inside this cell will be increased. And because of this increase in the density, I will get the hypereosinophilia. As you can see, I will get the eosinophilic neurons, and these are known as red neurons. Okay, because of the eosinophilic cytoplasm. I will get the pyknosis of my nucleus. Okay, and I will get the loss of nasal bodies. Okay, these are the basophilic bodies. If you stain the nasal bodies, you will see with the nasal staining, you will see the basophilic bodies inside the neurons. Because of my ischemia, all of my nasal bodies are lost. And even if I do the nasal staining, I cannot see any basophilic structure in my neurons, because these are all lost from the cell. Because you know that the cell membrane are damaged. In case of irreversible injury, I can get the loss of everything inside my cell, right? And so I will get the loss of nasal substances. When I do the nasal staining, I won't see any basophilic structure. I just see the red neurons or the hypereosinophilic neurons. Okay, and the injury will only be visible after 12 hours. And you can see, because the microscopic findings are only visible after 12 hours, the swelling would be present before the 12 hours. After 12 hours, what I will see is the shrinkage of the cells only. Is that okay?
Yeah.
So these are the findings I will see in the ischemia. Now comes the chromatolysis. Whenever I get the nerve dissection, okay, I will get the axonal reaction. And why this axonal reaction happening? In order to regenerate my cell. Okay. So what changes I can get on the cell? Because axons cannot regenerate themselves, because they do not contain any nutrition substance. They do not contain any organelle. They do not contain any nucleus. It is a cell body. It is a function of the cell body to regenerate my neuron again. Okay. So the axonal reaction is seen on the cell body side of the damage. What you will see is the enlargement of the cell body first. Okay, you will be seeing the eccentrically placed nucleus on the biopsy. You will see the dispersion of the nasal body to the periphery. As you can see, all of the nasal body, which is a very darkly stained, basophilic stained, they will find on the periphery of my nucleus, of my cell body. Okay, and you will have the enlargement of the nucleolus. Why you will have the enlargement of the nucleolus?
To make RNA.
Yeah, because in order to regenerate my cell, I need the proteins, and the proteins will be synthesized by the rRNA, which is synthesized in the nucleolus. So I will see the enlarged nucleolus. I will see the eccentrically placed nucleus. I will see the periphery distribution of the nasal body. I will see the swelling of the cell body, right? So whenever you see the swelling, you will think about the axonal dissection or the transection. Whenever you heard about the shrinkage, you will you will only think about the ischemic damage. Is that okay?
Yeah.
So these are the two damage happens in your brain. And
Yes.
now we will take a short break, and after the break, we'll discuss the chromatolysis or the regeneration process. Okay?
Yeah.
Any doubt?
No, thank you.
Okay, so we'll take a short break now. Now we are about to discuss the this chromatolysis, why this thing is happening, why the axonal reaction is happening. Well, this axonal reaction is happening in order to regenerate my damaged neuron. Okay, so basically what happens is there would be an increase in the protein synthesis in order, in an effort to basically repair the damage of the axons. You will get the round cellular siloing, you will get a displacement of the nucleus to the periphery, you will get the dispersion of the nuclear substance through the cytoplasm that we have discussed already, right? Very important. And then you will get the Wallerian degeneration. Okay, because in order to regenerate my neuron, all of this damaged material, it must be removed. Okay, so that a growth cone can form. As you can see, this growth cone can form and it will join the distal part of the axon. So basically the disintegration of the axon and the myelin sheath distal to the site of axonal injury with macrophages removing the debris. There will be a destruction of the axon and the myelin sheath, and it is done by the Schwann cells. Macrophages will be there because in the body you have the macrophages, in the brain you have the macroglial cells. So whenever this kind of a damage happens in the brain, okay, then the oligonucleotides will be the only cell try to repair that, but they will get die and they won't get any repair because the microglial cells, they are very slow cells. It would take time to organize these cells at the site of location, at the location of this injury, to regenerate my neuron. So that my CNS neuron cannot be regenerated. But in my periphery, I have the macrophages and they will be removing all the debris. Okay, Schwann cells are also helping them and removing all the debris completely. They will cause a disintegration of the axons and the myelin sheath. Okay, now proximal to the site of injury, all these changes are happening, and these changes will form the growth cone. Now this growth cone, when all these debris are now completely removed, it will look for the distal segment of the axon, it will join it, and it will form the complete neuron again. Okay, so the proximal to the injury, the axon retracts and the cell body sprouts a new protrusion that grow towards the neuron for the potential re-innervation. Okay, and this thing, it will take like years to happen, right? It is not that you have the injury and immediately you have the regeneration. Okay, it's not happen like that. It takes around months and years for the neuron to regenerate. Okay, very important. So as you can see, you will have the cellular swelling, displacement of the nucleus, dispersion of the nucleus substances. You will at the site of this damage, these things will be happening proximal to it. At the distal, you have this myelin debris. Okay, the macrophages will be infiltrate there and they will cause the removal of the debris so that the growth cone can look for the distal part of the axon. Okay, so this is known as a chromatolysis, and this is the axonal reaction, and this is the Wallerian degeneration. So the Wallerian degeneration, it happens distal to the site of injury. Chromatolysis and the axonal reaction, it happens proximal to the site of injury, right? And please note, in the periphery only you can have this chromatolysis complete. In the CNS, because the microglials recruit very slowly because of the blood-brain barrier. Okay, and by the time these microglial cells reach at the location of the injury, the oligonucleotide cells will die. Okay, they will get they will undergo the apoptosis, and as a result, they cannot assist in the phagocytosis. As a result, you will have a very slow removal of the this myelin debris. Okay, and this debris can be persisted for years. So whenever you have any axonal injury in the CNS and you do the biopsy of the patient, even after years later, you can see that debris there. So never a complete healing can occur whenever you get a CNS damage. Okay, and the astrocytes, they will form a scar around this site of injury. Okay, and this is known as the axonal reaction. Okay, any doubt on this part on the chromatolysis?
No, thank you.
And now what happens if this axonal cone, this regeneration cone which is formed, if this cone cannot find the distal part of the axon, what will happen to this cone? Does anyone know?
It'll degenerate.
No. It will form something known as the neuroma. It will become a mass. Okay. And this mass is known as the neuroma. This neuroma has a very high density of the sodium channels. Okay. And as a result, even a slight kind of stimulus can cause the impulse generation in this neuron. So whenever you touch, let us suppose you have a patient with a cesarean section and you somehow damage, the nerve there. And which nerve can be damaged with in the cesarean section?
Inferior hypogastric.
Yeah, you will get the hypogastric nerve damage. And, and because of this dissection of the nerve, the chromatolysis process happened. But somehow this growth cone, it cannot find a distal part of the axon. So what happens to this growth cone? It will become the neuroma. And even if you slightly touch that area, your hypogastric region, okay, you will get a very severe pain because of that.
Grant,
Okay,
you couldn't
so
even
it would be a
get the time to
patient.
look at this here. It was on the here.
Any doubt? It was so fast. Oh. Okay, so where were we? So yeah, if you encounter a patient who is having a recent history of any cesarean section or a recent history of any kind of surgery, okay, and you see that the patient is having a very severe kind of pain with even a slight touch, that's how you know that the patient must be having a neuroma. And the neuroma forms whenever this growth cone fails to find the distal part of the axon. Is that okay?
Yeah.
And the Steven will ask you why these neurons will become so much sensitive to the touch that they're causing this pain even with a slight touch. It is because of a high density of sodium channels. Okay, even with a slight impulse, they will cause a generation of action potential and they will cause the pain sensations there, right? So in order to prevent this condition, I mean, the neuroma formation has already occurred, but now you need to prevent this impulse generation. So what you can do, you can give the patient local anesthetic or the sodium channel inhibitors. Okay.
Yes.
That's about the this chromatolysis and the neuroma. Okay, you will see that neuroma in the axonal reaction here. That due to a nerve transaction, the violent degeneration occur, which activates the Schwann cells and the macrophages to remove the myelin. Okay, and then the growth cone will be formed, and the growth cone will look for the distal part of the axon in order to regenerate. But if this distal part is not formed, it will form a mass known as the neuroma. Okay, you will have an increased expression of the sodium channels there, and as a result, they generate a very high action potential, which causes the increase in the pain in these lesions. Is that okay?
Yeah.
So step one can ask you about these facts about the neuroma, why these, why they're having so much pain. It is because of a high sodium channel density.
Are the neuromas cancerous at all, or do they have any malignant potential?
No, these kind of neuromas, they do not have any malignant potential.
Okay, thank you.
It was a different type of neuromas. Okay.
Okay, we'll go over them in a bit. The other
Yeah.
ones?
The other ones what?
Okay, we will go over the other ones in a bit, right?
Yeah, of course.
Okay, thank you.
In the tumor section, we will discuss them. Okay. So now we need to study about the meninges. You have the dura mater, arachnoid, and then the pia mater. Okay. And the dura mater is formed by the mesoderm, arachnoid and pia mater formed by the neural crust cells. Okay. The CSF, it runs in the subarachnoid space. Okay, very important. Ultimately, the arachnoid granulations are present in the subarachnoid space. Okay, and they will get, and the CSF will get reabsorbed from this subarachnoid space into the veins. Okay, so the location of the CSF is in the subarachnoid space, very much important to note, which is between the arachnoid and the pia mater. Okay, then you have the epidural space, which is a space between the dura mater and the skull. Okay, the fat and the blood supplies are present here. Okay, so whenever you get a damage, whenever I say a damage of middle meningeal artery occur, that means that artery is damaged in the epidural space. Okay, and please note that the middle meningeal artery is a branch of maxillary artery, which is derived from the arc 1. Okay, and this artery can cause the epidural hematoma, if you guys remember.
Yeah.
Whenever this artery gets damaged, the blood will be accumulated within the epidural space, and as a result, you will get the epidural hematoma because of that, right? And yeah, that's all about it. And whenever you got any blood vessel rupture within the subarachnoid space, okay, where would you get the accumulation of this blood? Like in case of subarachnoid hemorrhage, where you would get the accumulation of the blood?
Like it'll be flowing in the CSF.
Yeah, it will be mixed with the CSF, all these sulci and gyri. Remember in the brain?
Yeah.
The blood will fill all the gyri, right? Sorry, the sulci, not the gyri. It will fill all the sulci, right? If I draw that, like these are the sulci and the gyri of the brain, let's say, right? And this is the arachnoid matter. Okay, because the pia mater is in a very close association with these the brain, right? So basically they form these sulci and gyri. So whenever a subarachnoid hemorrhage happens, it will fill up these spaces. Okay, and because you know that the CSF is also runs in the subarachnoid space, and you get the blood mixing in the CSF also, right? And that's why, because whenever the bloods get ruptured, sorry, whenever this vessel get ruptured, and you get the exacerbations of the blood flow of this blood, you will get the inflammation against the RBCs and the hemolysis of the RBCs, right? Whenever the RBCs get damaged, so whenever you get the exacerbations of the blood from the blood vessel, the RBCs can get damaged, right?
Yeah.
Yeah.
And whenever the RBCs get damaged, you will have the inflammation against these all the proteins in the RBCs, right?
Okay.
And because of that, you will get all this the symptoms similar to that of meningitis in case of subarachnoid hemorrhage, which is a neck stiffness. You must have heard about it, right?
Yeah. Yeah.
The
Yeah.
neck stiffness you get, it is because of this blood in the CSF. Okay, and that's why you will get something like xanthoma. Whenever you try to extract out the CSF, you will get this, the xanthochromia, right?
Yeah.
It is because of mixing of the blood with the CSF, the RBCs. Okay, and because of the inflammation, you will get the arachnoid, you have these granulations, the arachnoid granulations, okay, which will absorb the CSF ultimately into the veins, right? Because of the inflammation, you will get the scarring of these arachnoid granulations, and because of the scarring, you will have you won't have any absorption of the CSF, and you will get the communicating hydrocephalus in the subarachnoid hemorrhage. Is that okay?
Yes.
So these are the
Yes.
complications of the subarachnoid hemorrhage. You can get the inflammation, you will get the fever, meningitis, you will get the neck stiffness, you will get the communicating hydrocephalus because of the subarachnoid hemorrhage. And that's all because the CSF runs in the subarachnoid space, and from there it will get absorbed in the veins. Any doubt?
No, thank you.
We
No.
will recall all of these facts later in the pathology section. So do remember them. Then you have the blood-brain barrier, okay, and these are your blood vessels, as you can see, and these are the process of the astrocytes. And does anyone remember what type of junctions are responsible for the blood-brain barrier?
Tight junctions.
These are the tight junctions which are formed by what type of proteins?
Occludins and claudins.
Yeah, exactly. And these junctions, they will prevent any paracellular movement, which means a movement between these cells. Okay, a movement between these two cells, it will be prevented. As you can see, the junctions are present here, right? So no cell, no substrate can move between the cells. they need to travel through these cells, and only the lipid soluble substances can easily cross the cell membrane, and that's why they can easily enter the blood. They can easily enter the brain. No cell, inflammatory cell, can enter the brain because of these presence of these junctions. Okay. So the tight junctions, basement membrane, and the astrocytes, they take part in the formation of blood-brain barrier. Okay. Even the bacteria cannot reach to the brain through these blood-brain barrier. Then how does the bacteria can cause the encephalitis or the meningitis?
Damage to the blood-brain barrier,
How can they do that?
but destruction of the tight junctions.
That's not what they do actually. They can do, but that's not the reason they can reach to your brain. Any other? See, you have the, if I go back, you have the choroid plexus in the ventricles, right? And does anyone know how this choroid plexus forms the CSF?
Hyperfiltration.
Hyperfiltration. So basically they filter the blood and they will form the CSF out of it, right? So this area, in this area, you do not have any blood-brain barrier, right?
Yeah.
And all these bacteria, they first reaches here, and through the
Yes.
choroid plexus, they will enter the CSF. And because of the inflammation in the CSF in the subarachnoid space, you will get the symptoms of the meningitis, like the neck stiffness, right? The neck stiffness is only happens whenever you get an inflammation in the subarachnoid space, and that happens when the bacteria gains access to the subarachnoid space, and that happens because of the choroid plexus. Is that okay?
Yeah.
And that's why in case of a subarachnoid hemorrhage also, you will get the neck stiffness. Similar symptoms as that of meningitis, because in both of the pathologies, you're having an inflammation in the subarachnoid space. Any doubt in this fact?
What were the two you were saying? Uh, bacteria, and what was the other thing that would cause neck stiffness?
Bacteria can?
No, you said bacteria is going to cause neck stiffness because they're going to enter through the choroid plexus, but you also mentioned another pathology. What was the other pathology?
I told you about the subarachnoid hemorrhage and the bacterial meningitis, right?
Oh, okay. And you're saying
Yeah, in both of these conditions, you are having a this neck stiffness, and it is because of the inflammation of the subarachnoid space only.
Okay, thank you.
Okay. Yeah. So because of the presence of this blood-brain barrier, no drug, no bacteria, no cell can enter the brain. Okay. So bacteria can gain the access at the areas where the blood-brain barrier is not present, or these choroid plexus. Okay. So the glucose and the amino acids, they can enter the blood with the help of transport carriers which are present in these cells, right? Non-polar or the lipid substances can easily cross the blood-brain barrier because they are lipid soluble, of course. There are certain areas in the brain which are devoid of the blood-brain barrier, and we call them the circumventricular organs. And as the name suggests, they are present near the ventricles. Around the ventricles, these areas are present, which means any structure which are present near the ventricles, they contain these areas. Okay, so they have the fenestrated capillaries with no blood-brain barrier, and that includes the area postrema, okay, which is present near the fourth ventricle. And you know that because only circumventricular areas or the organs contain they do not contain the blood-brain barrier. So all these areas must be near the ventricles. One of them is the area postrema, which is present near the fourth ventricle, okay, and that contains the vomiting center. Okay, any chemotherapeutic drug which you give, they will travel to the blood, and from the blood they will come to that area, they will reach to that area, and through there they can cause the vomiting. Then you have the OVLT, which senses the osmolarity in the blood. Okay, this area is also devoid of the blood-brain barrier, and after sensing the osmolarity, it will give the impulse to the hypothalamus. Okay, and from the hypothalamus you can have a release of ADH, right?
Yeah.
Other areas includes the pituitary. Okay, from the pituitary you will have the need to secrete the hormones in the blood. Okay, so the pituitary is also devoid of the blood-brain barrier, right? And yeah, that's all the areas, the airpostoma, the OVLT, okay, and yes. So whenever you give the patient hypoosmolar agent like the mannitol, they can disrupt the blood-brain barrier, okay, and they will increase the permeability of other medications also, okay. So now, after that, you need to know about two type of edema. One is the vasogenic edema, and second is the cytotoxic edema. See, whenever you have the infarction or whenever you have the stroke, when the cell dies, you will always have an increase in the intracranial pressure or the cellular edema or the cerebral edema, we say, right?
Yes.
And that type of edema is known as the cytotoxic edema. The second type of edema occurs whenever the blood-brain barriers get damaged. And how does the blood-brain barrier get damaged?
Toxins and medications.
The medications are, yeah, of course, the mannitol, but second most important one is the inflammation, right?
Yeah.
Because of the inflammation, you can have a damage of the blood-brain barrier. The blood will start entering in your brain, and it will cause the edema there. And that edema is known as the vasogenic edema. So whenever you have any infarction, at the very initial hours of the infarction, like within 24 hours, I must say, in that duration, if you have the edema, you call it as cytotoxic edema because it is happening because of cell swelling of the cell. And that happens because of inhibition of the sodium potassium pump, right? And as a result, all of these electrolytes and the solutes will start accumulating inside the cell, and you will have a cell swelling, right? We have discussed that already in the cell injury part, right?
Yeah.
So because of that cell injury, you are having a cytotoxic edema. Now, after days later, because the neutrophils will arrive there at the location of infarction, the macrophages will arrive there at the location of infarction, you will have the inflammation there. And because of that inflammation, the blood-brain barrier over that area will get damaged. Okay. And then, after days later, you will get the edema again. You will get the high intracranial pressure again. You will get the headache and herniation, right? And that's because of the vasogenic edema. You guys getting my point?
Yeah.
So if the step one asks you a question about a patient who is having a high intracranial pressure shortly after the infarction, then this intracranial pressure rise is because of the cytotoxic edema. If they give you a patient who is having a high intracranial pressure and the headache days later after the infarction, that means it is because of the vasogenic edema. Any doubt?
No, thank you.
Then you need to know about the vomiting center, okay, which is basically devoid of the blood-brain barrier, of course. Okay, and yeah, you have this nucleus tractus solitarius, okay, which is present in the medulla, and this area is responsible for the vomiting. Okay, it receives the signal from the CTZ, which is a chemoreceptor trigger zone. We have discussed that this CTZ is located in the area post-trema, which is near the fourth ventricle, a circumventricular organ, right? It is devoid of the blood-brain barrier. So any drug reaches there, it will stimulate these receptors like the M1, H1, D2, 5S3, and given receptors. And whenever the receptors get stimulated, they will stimulate this organ and they will stimulate the nucleus tractus solitarius, and it will cause the vomiting, right? Inputs from the CNS reach there. Inputs from the GIT with the help of the serotonin will reach there. Inputs from the vestibular apparatus, which is in your ear, reach there with the help of muscarinic 1 and the histamine 1 receptors. Okay. So whenever you want to give a patient any anti-motion drugs, the anti-motion sickness drugs, okay, you will always want to inhibit the muscarinic and the histamine receptors for that, because these receptors are responsible for the motion sickness in your vestibular apparatus. So the drug includes a scopolamine, which is the muscarinic inhibitor. Okay, and then you have the diphenhydramine, okay, the maclazine, and the promethazine for the histamine inhibitors. Okay, for the GIT, you want to give the patient ondansetron, remember, which is an anti-emetic agent, right?
Yeah.
And that inhibits the serotonin receptors in the GIT, and that's why with any GI problem, whenever you get the vomiting, you always give the patient ondansetron, because you know that in the GIT you have the serotonin which will be inhibited by the ondansetron. With the chemotherapeutic agent, they will destroy the GI mucosa and it will send the impulses with the serotonin, and as a result you will get the vomiting. So in order to prevent the chemotherapeutic vomiting also, you want to give the patient ondansetron, right? Thirdly, you have the CTZ region, which is a chemosuppressive zone that are found in the area post-trauma, which is near the fourth ventricle. And these contain the receptors like the serotonin, NK1, D2, M1, and H1, mainly the serotonin, D2, and the NK1. Okay, so if you give the patient any ondansetron, which is a serotonin inhibitor, you will get the chemotherapeutic vomiting relief. If you give the patient NK1 inhibitor, which you guys already know, substance P, right? And the aprepitant, remember? Substance P inhibitor, aprepitant, we have discussed it in the GA section.
Yeah.
You will get the relief from the vomiting because of that. The D2 inhibitors like the metoclopramide, you will get the relief from the chemotherapy-induced vomiting. So do remember the CTZ, your stomach, your vestibular apparatus, and the brain, they all send impulses to the medulla, which is the nucleus tecta solitarius. Okay.
Yes.
So any doubt on this vomiting center?
I have a question on the blood-brain barrier.
Yes.
Since the hypothalamus is also secreting hormones, shouldn't the blood-brain barrier be absent in the hypothalamus?
Yeah, of course. In most of the regions of the hypothalamus, you have the absence blood-brain barrier. Like the OVLT region is in the hypothalamus only. This OVLT region, right? It is also absent. It is all devoid of this blood-brain barrier. So many regions in the hypothalamus are devoid of this blood-brain barrier.
Okay, got it. Thank you.
Any doubt on this page?
No, thank you.
Okay, now you need to know about the sleep pathology. Okay, but first you need to know that the suprachiasmatic nucleus is responsible for the sleep-wake cycle, okay, or the circadian rhythm. Okay, it is regulated by the suprachiasmatic nucleus. Okay, and the release of ACTH, prolactin, melatonin, norepinephrine, it happens in the circadian rhythm. Okay, so you have the suprachiasmatic nucleus, which releases the norepinephrine that stimulate the pineal gland to release the melatonin, and the melatonin is responsible for the sleep. You guys know that already, right? So signals are originate from the suprachiasmatic nucleus. They will stimulate the norepinephrine. They will release the norepinephrine. They will stimulate the pineal gland to release the melatonin, and that's how you get the sleep. You have two stages. One is the rapid eye movement stage, and second is the non-rapid eye movement stage. Okay, the initial one is the non-rapid eye movement, and then you will switch to the rapid eye movement, and then you will switch back into the non-rapid eye this movement stage. Okay, you also need to know how the age, how the depression, how certain drugs affects your sleep cycle. So for the alcohol, benzodiazepines, barbiturates, okay, they basically decreases the REM sleep cycle and the N3 sleep. Okay, the rapid eye movement and the N3 part of the non-rapid eye movement sleep, it will be decreased by the benzodiazepines, barbiturates. Okay, the norepinephrine, it will decrease the REM sleep. Okay, with the elderly, with the old age, you will have a decrease in the REM sleep and the N3 sleep, which is same as that of alcohol, benzodiazepines, and the barbiturates. Okay, with the depression, you will be having an increase in the REM sleep time and decrease in the REM sleep latency, as well as decrease in the N3 sleep time. So basically, with the depression, you will get more of the REM sleep and less of the non-REM sleep. With the elderly, you will have a decrease in the REM sleep as well as N3 sleep. With the alcohol, benzodiazepines, barbiturates, you will have a decrease in the REM and the N3 sleep. Okay, so that's why, because you will study that later, that the REM sleep are basically responsible for the night terrors. Sorry, the N3 sleep is basically responsible for the night terrors and for the night dreams, for the very kind of nightmares. Okay, the REM sleep is responsible. So the benzodiazepines, because they are decreasing the N3 sleep and the REM sleep, they are very useful for the night terrors and the sleepwalking. Okay, very important to note. In the narcolepsy, you're having an increased REM sleep time. That means a decrease in the latency and increase in the time. So as a result, you will get more of the REM sleep, and that's why you will get the sleep paralysis in the narcolepsy, because in the REM sleep you will be having a paralysis. Okay.
Yeah.
So with these things in mind, let's discuss these ECG waves and the stages of the cell of your sleep cycle. Okay, so for the waves, you need to remember the mnemonic, which is the bats drink blood. Okay, B for beta waves, A for alpha waves, T for theta waves. Okay, as for the spindles, okay, or the K complexes, you can say. Then drink, the D for delta waves, and blood again for the beta waves. Okay, so first you have the awake. You guys are now awake, and the waves which are generating in your CNS, these are the beta type of waves, which have a very low amplitude and a very high frequency. Okay, as you go down, okay, the frequency decreases and the amplitude increases. Okay, as soon as you close your eyes, the beta waves will switch to the alpha waves, and these alpha waves have a decreased frequency and an increased amplitude. Okay, then you go to the non-REM sleep cycle, and the first stage is the S1, the N1 stage. You have a very light sleep, okay, and easy to wake up. The waves in your brain are the theta waves, which again have a very low frequency and a high amplitude, more than the alpha waves, of course. Then you have the N2 stage, which consists of about 45% of the total sleep. Okay, if you sleep for 8 hours, then 45% of times, okay, total duration, you will be in the N2 stage. It is a deeper sleep. Okay, the teeth grinding that you see, and this teeth grinding can also leads to something known as this the temporomandibular joint disorder. Remember?
Bruxism.
I'm talking about a temporomandibular joint disorder. You guys know about that?
Yes.
If not, don't worry, we'll study it later again. But
Yes.
the cause of this temporomandibular joint disorder is the bruxism, and that happens in the N2 sleep. Okay, so teeth grinding occurs in the N2 sleep, and in this sleep you will be having a spindles or the K complexes, which refers to the bats as part of the bats. Then you have the N3 sleep, which consists of about 25%. The night terrors, the sleepwalking, bedtime, bedwetting, it is occurs in the N3 sleep. And please note, patient do not have any memory of this N3 stage. Whatever the dream saw, whatever dream they saw in this N3 stage, whatever they do, the night terror, the sleepwalking, the bedwetting, they do not have any memory of these episodes. So whenever you encounter a patient, okay, who basically describe you some, if the question is some describe you a scenario in which the patient do not remember their dream, that means they watched the dream in the N3 sleep. If they remember their dream, that means the dream was watched in the REM sleep cycle. Okay, so this is a very a very important way which by which you can differentiate between the N3 cycle and the REM sleep. Okay, for the night terrors, you do not have any kind of memory of the night terrors, what dream you saw in that time. You do not have any memory of that. You just are very shouting in the sleep. Okay, you're moving your hands. Okay, you're crying in the sleep, but you do not remember any episode if that happened. Okay, sleepwalking is done in the NC sleep, but you do not have any memory of the sleepwalking. Bad wetting is done, but you do not know why you done the bad wetting because you don't have any memory of that. Okay, so and note that it is prominent in the first half of the night. Okay, and then it will start decreasing. Okay, so patient will scream while sleeping. Okay, but they do not have any memory. So it would be it would be a child who basically who basically screams in the sleep, and the patients and the parents of the child mention you this, and they will tell you that the child has no memory of that events. That means they're talking about the N3 stage. Then you have the REM sleep cycle, and where whatever dream you saw in the REM sleep cycle, you have a memory of it. Okay, you have the nightmares in that sleep. Okay, all of the muscle functions are kind of inhibited in REM sleep. You will have a loss of motor tone. You will get the paralysis in the REM sleep. Okay, and the brain will use more oxygen. Okay, and you will have a high acetylcholine in that time. You will have the penile or the clitoris transluminescence in this stage. Okay, and it may basically serve the memory processing function, because in the REM sleep cycle, your brain is basically, the brain is processing all the memories which you saw throughout the day, and that's why whenever you see any dream, okay, it will be always related to what you did during that day. If you watch a movie, you will get dreams of related to a movie. If you imagine something, you will get a dream related to that imagination. And that happened why? Because your brain was processing all these memories throughout the day, and while the brain was processing these memories, you will watch these dreams related to them. Okay, you will have the memories of these dreams completely. You will have the extraocular movement, and that's why this sleep is named REM sleep, the rapid eye movement sleep, because you have the rapid eye movement in this uh, sleep cycle. Okay, sleep phase. And it is because of the activity of the PPRF, parapontine reticular formations, okay, which is a gaze center. You will say that later again, don't worry. Okay, it occurs after every 90 minutes. Okay, and the duration basically increases throughout the night. So this 90 minutes is actually a latency of this sleep cycle. Okay, and with the age, the latency will increase. Okay, with the depression, the latency will decrease. With the narcolepsy, the latency will decrease. And whenever you have a decrease in the latency, the frequency of this REM sleep will increase. Can I say that?
Yeah.
So the frequency of REM sleep increases in the narcolepsy and in the depression. Frequency of this REM sleep and the duration of the REM sleep decreases in the elderly, in the alcohol, in the benzodiazepines, in the barbiturates. Okay, so yeah, and whenever you sometimes you woke up and you get paralyzed. If you woke up paralyzed, okay, that means you directly woke up from the REM sleep, and slowly you will regain the motor functions. It happens sometimes, right? I think with all of you, it would have happened, right?
Yeah.
So, and why this happens? Because you directly woke up from the REM sleep. Any doubt on this page?
Could you repeat what happens to the REM latency in elderly?
In the elderly, you will be having a decrease in the REM time, okay, and increase in the latency. And as a result, the frequency of the REM sleep decreases, and the duration of the REM sleep also decreases. Okay.
Okay. Yeah.
Similar thing can happen with the alcohol, benzodiazepines, and the barbiturates.
Okay. Okay.
You will be ultimately having a a decrease in the REM sleep.
Okay. Thank you.
So when you take barbiturates or alcohol, you I thought you have like an overall increase in sleep. So the overall increase in sleep is of the N2 stage because by N3
Yeah.
and
Yeah. The largest stage in your sleep time is the N2 stage only, right?
Mhm.
And when you take the alcohol, this N2 stage time will increase, the N3 time will decrease, the latency and the duration of the REM sleep will also decrease.
Okay, thank you.
Now you have the hypothalamus, okay, which basically maintains the thrust and the water balance. Of course, you have the OVLT for the water balance, the regulatory center. Okay, you have the adenohypophysis, okay, which controls the you have the hypothalamus controlling the adenohypophysis. That means the anterior pituitary. You have the hypothalamus, which stores its hormones in the neurohypophysis, right? You have the hunger center in the hypothalamus. You have the ANS center in the hypothalamus, right? You have the temperature sensor in the hypothalamus, and the sexual urges starts in the hypothalamus. Okay, inputs are not protected by the blood-brain barrier like the OVLT region we have discussed, right? Like the area post-tremor. Okay, it is found in dorsal medulla. Okay, and response to emetics, and the hypothalamus also takes part in it, right? So these areas are basically devoid of the blood-brain barrier. Any input in the hypothalamus devoid of the blood-brain barrier. So these are all the functions and you must remember the functions. Okay. And do note that this hypothalamus is formed by the diencephalon, right? You have telencephalon forming the cerebral hemispheres. Then you have the diencephalons forming what structures?
Hypothalamus and the retina and the
Hypothalamus, thalamus, hypothalamus, retina. Then you have the the mesencephalon forming the midbrain. Then you have this metencephalon forming the pons, and the myelencephalon forming the medulla, right?
Yeah.
So do remember this thing also. So hypothalamus, we have first the lateral nucleus. We have discussed that already in the GI in the endocrine section, that the lateral nucleus is responsible for the hunger. And whenever you have a damage of the lateral nucleus, you will get lean. Okay, so the easy way to remember the function is whenever you get a damage of the lateral nucleus, you will become very lean. You will lose the body weight. Okay, and please note that the the ghrelin actually act on this nucleus, and it will stimulate the hunger, and the leptin inhibit this nucleus. Okay, ghrelin activated, leptin inhibited it. So whenever you have a damage to lateral nucleus, you will have a lean body weight. Then you have the medial nucleus, or I can say the ventromedial nucleus, which basically stimulates some satiety. Okay, and whenever you have a destruction, you will have the massive weight. So a ventromedial injury will make you very massive, because in that area it is stimulated by the leptin, which inhibit the hunger, and this area is inhibited by the ghrelin, which stimulates the hunger. Then you have the anterior nucleus, and you can remember the anterior by the term AC, which is for the anterior cooling. Okay, because this center is involved in the cooling whenever you get the hyperthermia. Okay, whenever you get a very high temperature in your body, this system will get activated. Okay, it will activate other parts like the parasympathetic system, like the vasodilation, high heart rate, right? Blood flow will be increased so that the this heat could be exchanged. The thyroid hormones will be decreased so that you won't get the heat, right? So all of the counter-regulatory mechanisms will get activated to dissipate the body heat, right? And the responsible nucleus is the anterior nucleus. Whenever you get the hypothermia or a decrease in the temperature, the posterior nucleus of the hypothalamus can get activated, and it will cause the heating. Okay, and it will also stimulate the parasympathetic system so that the shivering can occur, thyroid system can get activated, right? So all these things can lead to the increase in body temperature. Then you have the suprachiasmatic nucleus in the hypothalamus, which will be responsible for circadian rhythm. We have discussed that already. You have the supraoptic paraventricular nucleus, and you guys already know about them from the endocrine, that they're responsible for the ADH and the oxytocin. You have the preoptic nucleus, okay, and they basically are the thermoregulation. So both the anterior posterior nucleus and the preoptic nucleus are responsible for the thermoregulation. Whenever you have a damage to that area, to that nucleus, you cannot maintain the body temperatures. Okay, it can either cause the hyperthermia or it can cause the hypothermia. Okay, sexual behaviors are controlled by the preoptic nucleus. GnRH is released by the preoptic nucleus, and whenever you have a damage of this preoptic nucleus, you cannot have the GnRH, and what you get is the Kalman syndrome, in which you're having a loss of GnRH. You will get the you will get a low level of FH, LSH. Okay, you will get the hypogonadism, right? And you will get a loss of the olfactory system also, right? So you cannot smell anything. So loss of senses along with the hypogonadism. That means the patient is having a Kalman syndrome, anosmia with low level of GnRH. Is that okay?
Yes.
Any doubt on any nucleus of the hypothalamus?
No, thank you.
Okay. So we will wind up here for now, okay? And from tomorrow we'll start at this thalamus. Is that okay?
Yeah.
Yeah.
Okay. Thank you so much.
Thank you so much.
Thank you so much.
Thank you.